Take it. Thank you so much, everyone, for coming. We're really honored by the guests that they have accepted our invitation. For the first session, I'd like to introduce the chairs. First, we have Professor Dr. Ali Sheikh, who's a pediatric surgeon at Sheikh Zayed Hospital. And then we have Dr. Sadia Anwar, who is an associate professor of pediatric hematology oncology at Children's Hospital, Lahore. So thank you so much.
So, Bismillahirrahmanirrahim. Assalamu alaikum, everyone. So, we're going to start our first pediatric oncology session on Wilms tumors. So, we will have three talks in this session, followed by the panel discussion. So, I would like to invite our first speaker, Dr. Bilal Mazhar Qureshi. He is an assistant professor in radiation oncology at Aga Khan University, Karachi, and he is a section head of radiation oncology. His special interest is in pediatric lymphoma and pediatric solid tumors. He is also a lead person for developing radiation guidelines for the LMIC. So he's going to talk about radiation treatment for Wilms tumor, a modern perspective.
Assalamu alaikum, everyone. Thank you so much, Dr. Alina, Dr. Naeem, and the entire organizing and scientific committee for having me here to talk about the radiation oncologist perspective of treating the Wilms tumor. I do not have anything to disclose. Yeah. Okay. So I do not have any financial disclosure to talk about here about this presentation or the title of the talk, but these are some of the associations or engagements that I have for pediatric radiation therapy, radiation oncology with different societies. So during my presentation, I would like to talk about the introduction, how the use of radiation therapy and different PSYOP protocols, the local treatment evolved over the years, the indications of radiation therapy and how to do it. A little bit about conformal radiation therapy, which is practiced at some institutes in Europe, about the modern trends, the quality assurance requirements, especially the Pakistani perspective, and then we can conclude it together. So as we broadly know that there are two distinct strategies to deal with Wilms tumor, which includes the North American strategy that begins with upfront surgery, and the PSYOP or the European strategy, which begins with chemotherapy followed by nephrectomy, and based upon that, histological stratification is done and further treatment is offered. So since I'm more accustomed to the PSYOP European strategy, since that is the consensus between the pediatric oncologists in Pakistan, so most of the things in my presentation would be revolving around the PSYOP strategy, which begins with preoperative chemotherapy. But how did this actually evolve over the years? So like anywhere else, usually surgery alone was done to deal with Wilms tumor, like most of the cancers historically, but that did result in a lot of spillage and higher risk patients, high risk of relapses. So the first PSYOP study looked at the use of radiation therapy in the neoadjuvant setting. Also, there was a chemotherapy arm to it, whether to offer 1 or 6 cycles of actinomycin D after surgery. But it did show that offering radiation therapy in the neoadjuvant setting, that is before going for surgery, did result in lower risk of recurrence and lower risk of spillage. The following study did evaluate the use of postoperative chemotherapy for 9 months versus 15 months. However, it did not show any benefit, but then some of the smaller tumors which were looking operable to the surgeon were allowed to be operated. However, what they learned that the temptation to operate on smaller tumor proved to be risky for the patient, and that could end up in having a rupture of the tumor. So that's how the recurrence-free survival looked like in this particular PSYOP study, based upon the patient who had rupture versus no rupture of the tumor per operatively. So the following set of studies, particularly the PSYOP-5 study, looked at whether chemotherapy could replace neoadjuvant radiation therapy, and it was proven that there was no difference between the two neoadjuvant treatments in terms of stage distribution post-operatively or the tumor rupture, and both the arm had equal results in terms of actual survival. So that's how you could see the risk of rupture and the survival improved with the PSYOP 1 to PSYOP 5 study. So from 1980 to October 1987, the PSYOP study had three randomization: whether to avoid long chemotherapy in stage 1 tumors, whether radiation therapy could be avoided in stage 2 tumors, and if more chemotherapy should be given in the stage 2 node positive and stage 3 tumor according to the staging at that time. And it did show that the benefit of more chemotherapy was not there in the stage 1 tumors. For the randomization related to radiation therapy for stage 2 tumors, there were some relapses happening during the course of study. Therefore, this particular arm was stopped. However, later on longer term analysis, it was found that there is no difference between radiation versus no radiation in the stage 2 tumor. So therefore, it could be concluded that radiation therapy can be omitted from this particular subset. So the next, I would talk about the PSYOP-9 study, which looked at whether a prolonged chemotherapy of 4 weeks versus 8 weeks could improve or result in any advantage, which showed that the further more cycles of chemotherapy up to 8 cycles did not improve in terms of the advantage of in terms of relapse of the disease. So the PSYOP 9301, which is kind of a precedent to the last updated results from 1983 to 1999, has more than 1,000 patients randomized for stage 1 disease to chemotherapy versus maintenance chemotherapy after having surgery. So there was no difference in 2-year event-free survival between the no further therapy group compared to those who received additional chemotherapy. So therefore, what we have today is the established upfront chemotherapy followed by surgery and post-operative treatment as part of the umbrella protocol, which was launched around 9 years ago. So over the years, as we see that the radiation therapy for this Wilms tumor have evolved, not in terms of conformity or higher technology, but its utilization has decreased from up to 90% in the first two set of PSYOP study to up to 24% in the recent set of study. So basically, the treatment with radiation therapy, of course, with chemotherapy post-operatively as well, is related to the histological classification that is done on the nephrectomy specimen after chemotherapy is already given. So regarding the stage of the disease, when it is completely confined to the kidney, all the margins are negative. It is broadly termed as stage 1 disease. According to the PSYOP strategy, fine needle aspiration or percutaneous core needle biopsy, he does not upstage the tumor. However, if the biopsy is open through laparotomy, or through an incision, it is termed stage 3. So the PSYOP now has some guidelines on how to approach the Wilms tumor initially, and what are the indications of doing a biopsy upfront in these children. For stage 2 tumors, the tumor may be extending beyond the renal capsule or the kidney. It may be that the fibrous pseudocapsule is infiltrated, or the vena cava or adjacent organ has tumor infiltration, but as long as it is completely taken out, it is termed as stage 2, provided the margins are completely negative. So it is the stage 3 for which most of the intermediate risk tumors would require radiation therapy, but that would be the risk of having microscopic disease left behind, maybe due to positive margins, spread of the disease, peritoneal spillage, be it preoperative spillage, or due to tumor rupture during surgery whenever there is a thrombus which is resected in piecemeal fashion, or the tumor resected in piecemeal fashion when there's lymph node positivity, or when a wedge biopsy is done. So stage 4 means hematogenous spread outside the kidney. So stage 5, when is the only disease where we have stage 5 disease, and that is when you have bilateral disease present. So the aim of radiation therapy is to achieve local control of abdominal disease, especially in those patients where there is significant risk of intra-abdominal relapse rates, and to increase the control of pulmonary metastasis, especially in those patients where there is incomplete remission after chemotherapy. Radiation is also used to increase the control of hepatic metastasis when chemotherapy fails to achieve a complete response, or there is R1 resection of hepatic metastasis or gross residual disease in the liver, even after surgical resection. Very rarely, but it may sometimes be used for brain or bone metastasis as well. So looking individually at each of the flank radiation therapy, which includes radiating the preoperative extent of the tumor and the kidney, it is done for intermediate risk tumors when there is no positive disease, residual disease after surgery, or tumor rupture confined to the surgical field. For all high-risk patients, radiation therapy is given except for stage 2, which are blastomal type, because the blastomal type stage 2, according to the PSYOP data, has risk of distant failure, but not local failure at the tumor bed or the nephrectomy site. So all high-risk patients get radiation therapy for stage 3 disease, and for stage 4 and stage 5 would get radiation therapy according to the local stage. So this is very important for the fellows to understand that the decision for radiation therapy is done after nephrectomy and according to the local stage. So stage 4 tumor may have local stage 1 or 2 disease, low risk or intermediate risk, that may not warrant local radiation therapy. So the outcomes of patients with Wilms tumor stage 2 due to positive resection margin was evaluated as part of the German, UK, and the entire PSYOP European data. So they categorized patients which were historically defined as any viable tumor present at the resection margin, be it vessel or the renal sinus or any other margin, or whenever there was chemotherapy-induced changes at the resection margin. So what they found that there is no risk for those patients, and no local recurrence for those patients who do not have viable tumor present at the resection margin. And they did subset analysis for stage 4 patient in terms of local control as well as survival and local relapses. And they found that through different subgroup analysis, it's only the presence of viable tumor at the resection margin, and therefore it was proposed that the patient who had uh, chemotherapy-induced changes at the resection margin could be omitted from stage 3 group, and hence radiation could be avoided. Abdominal radiation therapy is offered for those patients who have diffuse intra-abdominal tumor or gross pre or perioperative abdominal rupture. And if it is due to rupture peroperatively, radiation therapy should be done within 2 weeks after abdominal surgery, and that remains a challenge for many radiation therapy centers or even in well-resourced settings because there are a lot of challenges starting radiation therapy on time, post-operative recovery, as well as availability of the pathology report. So exceptions for starting whole abdominal radiation therapy immediately is for those situations where you may have to irradiate the lungs as well. So if there is a decision to be taken for lung radiation therapy, you may have to hold, and that's the reason because you would not like to have overlapping of the lung and the abdominal field. So therefore, for those patients whose lung radiation is anticipated, abdominal radiation therapy is delayed till we evaluate the lung at 10 weeks and then do it simultaneously. So broadly, all high-risk patients would get radiation therapy to the bilateral lung. All the low risk would not require radiation therapy, and it's often very complex to make a decision about the intermediate risk disease. If it is residual disease, which is not operable, or lung nodules cannot be taken out, all intermediate risks have to be irradiated, or whenever the nodules are taken out and they prove to be positive or are margin positive, then intermediate risk would also get radiation therapy. Hepatic metastasis need radiation therapy to the whole liver when if they fail to achieve a complete response with chemotherapy. And as I said, to other organs, radiation could be given. So I'll be quickly going through the fields of radiation therapy, would not go into the details because the protocol does define it in a very good way. And still, the SIAP-RTST umbrella protocol provides radiation therapy planning according to the field. It's not highly conformal radiation therapy that is recommended. So usually you need to have access to the pre-surgery post-chemotherapy scan to see the extent of the disease, which is given a 1 centimeter margin all around, and the entire vertebra has to be incorporated into the field. If there is residual disease along the nodal chain, that would require an extra boost of 10.8 gray around the gross nodal disease which is left behind, which should not be happening if a good surgery has already been done. Similarly, if there is a residual lesion somewhere in the abdomen, that nodule or residual disease has to be radiated with a boost of 10.8 gray. So this is very important to understand here, and therefore evaluation of the thrombus is very important. Whenever there is a thrombus extending from the kidney into the inferior vena cava, the proximal extent of the thrombus has to be covered. And sometimes it turns out to be very complex that the thrombus is extending up to the right atrium into the heart, and that's for the radiation oncologist, it's always a worry to include a portion of the cardiac tissue in the field, but that is required to get rid of the disease, and the doses are eventually lower. So an APPA field could spare a good portion of the heart as well. So whenever we say that a boost is to be given to the residual thrombus, which should be given because often it is not possible to do a combined surgery along with the vascular surgeon, cardiothoracic surgeon, and the primary pediatric surgeon to take out the thrombus. Therefore, we need good imaging to delineate the thrombus and take out to incorporate the thrombus in the boost field as well. So again, an image to show how flank radiation therapy is used. And here it is very important to understand why vertebral body are in the radiation field. This is due to the fact that inhomogeneous dose to the vertebral body could result in kyphosis and scoliosis. Therefore, therapeutic dose is given to the vertebral body area. So this is the field, which is an extended flank field done whenever there is a spillage into the field of the surgery, and that's where you cannot get that information out of the pathology report. You need to talk to the surgeon and know about the what happened during the surgery through the per-operative notes. I'm sure Dr. Salim would be highlighting that during his talk. Yeah. But you have to tell us the secret, and we have to find a way to standardize how the secrets are documented, right? So yeah, so whenever there is spillage into the abdomen, be it peroperative, perioperative, or even a diagnosis, the whole abdominal radiation therapy has to be included, very well covering the dome of the diaphragm as well as the obturator foramens. So this is the field of the pulmonary radiation where you have to cover the recesses on both sides of the diaphragm below. So the umbrella PSYOP RTSG protocol does define the doses to for different fields and different risk stratification. Even during the planning, we try to consult and follow these guidelines for every patient. So whether a boost is required whenever all the nodes are positive and you're radiating just because of stage 3, this was looked at in the retrospective analysis by the PSYOP group for those patients who got a boost along with the flank and nodal radiation versus those patients who did not get a boost, and the patients who did not get a boost to the nodal field in patients who there was no gross residual disease in the paraortic region, there was no benefit in terms of event-free survival, local control, or overall survival. Therefore, the boost can be omitted in such patients. So usually a dose of 12 gray is given, and that's the learning coming out of the COG data that usually in the previous set of PSYOP study only 15 gray was given, but now based upon the PSYOP results, 12 gray is given. So this shows the outcome of high risk patients, showing that the diffuse anaplasia does worse than the Wilms tumor with blastomal histology, and metastatic directed radiation therapy does improve the outcome in patients with stage 4 disease as well. So this was analysis of the various countries from Europe treated on PSYOP strategy, showing improved event-free survival and overall survival for diffuse anaplasia even before without aggressive treatment. So there has been a lot of advances in the clinical management of high-risk Wilms tumor, but the outcome between the resource-limited setting and the well-resourced setting varies. So now jumping out to the modern technology, the Utrecht group with Princess Maxima Cancer Center has used the technology to do highly conformal radiation therapy where only the potential high-risk area like the parotid region and where the renal tissue was adherent to the abdominal wall is irradiated as compared to the APPF field. And what they found through their patients for whom this highly conformal radiation therapy is done, they did have few relapses, but mostly those relapses were in an area where either whole flank radiation therapy would not have been giving a potentially therapeutic dose or at a place which is within the radiation treatment field uh, uh, of the flank field. So there's a potential role of MRI too. The Utrecht group again looked at is how it could help in decreasing the dose to the upper abdominal structure and avoid potential effects to the spleen and the metabolic consequences. However, they are even not following it and due to resource limitation and access to MR-based treatments. So how they came up with this idea of doing highly conformal radiation therapy is through the mathematical calculation which one of their PhD students did, and they came up with some suggestion that where to end the highly conformal radiation therapy volume and how to document and follow the peroperative findings. So another innovation recently is the whole lung radiation therapy guidance that we have from the COG protocols, where they give guidance on how to spare the heart through simultaneously integrated radiation therapy for Wilms tumor. However, it may be challenging when an overlap is to be done with the flank radiation therapy APPA field. So that's how we learn that even in the most modern area of proton and highly conformal radiation therapy, COG is still doing APPA technique. So there, to deal with the radiation different treatment dose and volume differences between the PSYOP and the COG group, there's this harmonica group which addresses the different methodological and resource utilization between the two strategy, and it's studying the late effects of radiation therapy. So w- some of the important points that we need to consider and help us improve the treatments for Wilms tumor with radiation therapy is to have better integration in a multidisciplinary format, provide access and availability of radiation therapy expertise as well as the machine and resources, proper following the indication and technique and the doses according to the guidelines. Some of the things which PSYOP TSG is looking at now and coming up with the publication includes outcome of metastatic disease in younger children less than 2 years of age. What are the outcomes was stromal versus epithelial type stage 4 cancers, whether flank radiation could be omitted for those patients for whom it's only stage 3 because of the nodal disease, and whether artificial intelligence could help us in plans. So we now have the PSBO national protocol with efforts of our senior colleagues, and within that, which is following the PSYOP strategy, we try to include the documentation and collection of all the data related to the radiation treatment. But what we are not doing right now, but aim to do through our effort, is something called the pre-treatment quality assurance, which we learned from the IROC experience in North America and the Quartet experience in Europe. So what they recently did for the last 6 or 7 years is to move from the post-treatment quality rounds and reviews of the treatment plans to the pre-treatment rounds. So through this, they try to review every patient before the treatment is given, and that incorporates up to 40% changes. Many of them are unacceptable deviations, but they are able to correct them through reviews in up to 90% of their patients. So what we try to do is to every alternate week provide an opportunity for any pediatric oncologist or radiation oncologist to discuss their cases. So far we have been able to do 46 meetings over the last 2.5 years, and the change rate in comprehensively on all those patients have been up to 70%. And it is not just the changes in the radiation treatment plan and doses, and especially for Wilms tumor, it has been changes in their histologies as well as the risk stratification, as we look into the more details and advise to have consultation within the multidisciplinary team. So it's not just a specific patient QA, but also helps identify the service needs as well as the educational gap in pediatric radiation therapy. So moving forward, we are trying to do it through a project called Proper Night Pediatric Radiation Oncology Peer Review Network, which not only provide an opportunity to do weekly or fortnightly peer review meeting, but also have educational workshops. The learning objectives of those would be coming out of the peer review meeting and possibly provide an opportunity to clinical attachment at high resource setting. एक slide रहेगी. Yeah. So yeah, so you don't have to read through it. You'll experience it over the next few years, provided you support the Proper Night program. And I would end up by concluding that we need to have, for adequate radiation therapy, good surgical notes, histology, histopathology reporting, which always I try hard to do, but still we are learning because it's so tough to talk to a histopathologist for me. So we need adequate imaging, immobilization devices, peer review. And then I believe that multidisciplinary and close collaboration with the pediatric oncology colleagues, radiologist, and the surgeon is the key for better outcomes in Wilms tumor. Thank you.
Thank you, Dr. Bilal. At the end, now it gives me pleasure to introduce Professor Salim Islam. He's going to talk next, and he's a pediatric surgeon, chair of Department of Surgery at Khan University. He has special interest in pediatric surgical oncology and surgery for congenital anomalies. Dr. Salim has special interest in research, and his research focuses on performing outcome-based research pertinent to all aspects of pediatric surgery, and he will be talking about how can we advance surgical care for Wilms tumor in low and middle income countries.
तो लगता है आप लोगों के पास तो किल स्विच है ना बंद करने के लिए तो वी शुड मेक श्योर वी स्टॉप एट ऑन टाइम सो माय टॉक्स कैन बी अ लिटिल डिफरेंट ऑडियंस में सर्जन्स कितने मेरे और अली के अलावा सो वी हैव 5 पीपल इन टोटल इंक्लूडिंग मी एंड अली तो हम लोग आपस में बात कर लेंगे और हम विल गो इनटू द वीड्स अबाउट सर्जरी बट what I was asked to talk about was how do we advance the surgical care, but जिस तरह बिलाल ने भी कहा है आप सर्जरी को रेडिएशन से या ऑन्कोलॉजी के जो ड्रग्स हैं और ऑन्कोलॉजिस्ट से डिवोर्स नहीं कर सकते ये इन सबको मिला के ही देखना होगा सो इट्स नॉट लाइक surgical care is different from anything. We can talk about nodal dissection, we can talk about adequacy of all that stuff. It's not going to necessarily help most of you. So we're going to try to focus on what we can do for Wilms tumor in Pakistan and what has been done so far. So I don't have any financial disclosures. I would like to have had financial disclosures, but I don't have any. We're not discussing any off-label uses, but I did want to disclose कि मेरी training और मेरी practice ज़्यादातर जो हुई है वो COG NWTS के अंदर हुई है और वहाँ पे हमें सायाब के बारे में कुछ बताया भी नहीं जाता था बस ये कहा जाता था ये लोग देखो कितने बेवकूफ़ हैं कितना कीमो देते हैं हम तो निकाल देते हैं मैं कहा हाँ आप बिल्कुल सही कह रहे हो I'd also like to thank the organizing committee and Dr. Alina and everyone else who gave me the honor to come here and give you a talk on this. So thank you very much. And we really appreciate what Shaukat Khanum is doing for cancer across the country. And I have been a donor for at least 2 decades now. So इसके objectives जो हमारे होंगे वो we're going to just very briefly go about the history of Wilms and the treatment. और हम जो COG और सायाब की बात करेंगे उसका मकसद एक कहानी है एंड स्टोरी इज इम्पोर्टेंट एंड एज यू टेल द स्टोरी इनमें जो लेसन्स हैं दे आर द लेसन्स दैट वी नीड टू लर्न अनफॉर्चुनेटली दिस लेसन्स आर फ्रॉम 40-50 years ago और हमें अब सीखने पड़ रहे हैं nevertheless it is important for us to kind of know that we'll then rapidly go down to the epidemiology of Wilms in this region and in LMICs जो पाकिस्तानी डेटा है and what we know and then किस तरह से अब आगे बढ़ना है हमें So what is the context of Wilms tumor that we need to know? Childhood cancer is a big killer. 80% of all, I can stop. all of you are sitting here because you are either pediatric oncologists, pediatric surgeons, or pediatric something fill in the blank, or something like that, or radiation oncologists. I don't have to convince you of any of this, or this, which is that every child with cancer deserves the optimal treatment, no matter where in the world they live. So we'll go over to a history of Wilms. These were supposed to come up one by one, but they just kind of all popped up. So it was described in 1899 by a German surgeon, Max Wilms. And it is an embryonal tumor, as we all know, thought to arise from nephrogenic rests. And a vast majority of them, because of the fact that इसकी embryonal origin है, they arise before 5 years of age. In fact, अगर 5 years के बाद होते हैं, तो we all know कि उसकी जो prognosis है, वो इतनी अच्छी नहीं होती है. There are multiple syndromes and genetic linkages which have been reported. A lot which of these data come from the West. And Wilms ने जब report किया था इसको, the survival long term was 0. Surgery जो है 1920 तक 1925 तक थोड़ी सा improve हुई थी, and the outcomes went up to about 25%. Radiation was actually added, जिस तरह बिलाल ने कहा था, before surgery. And so it was radiation and surgery initially. उससे 50% लोग बचने शुरू हो गए 2 साल तक. And then when you added chemo to it, और उसकी कहानी भी बड़ी अच्छी है, but we're not going to go into it, then 75% तक survival चली गई थी. And Wilms tumor is the prototypical tumor जिसमें इन तीनों को मिला के जब उसका हसीन इम्तिजाज आप करते हैं, तो then you get the best outcome. So Wilms defined that collaborative therapy and care, multimodal care. So then the story comes. The first story is that of the NWTS and the Children's Oncology Group. And that starts when we knew that 75% आपकी survival पहुंच गई थी 1960 के आखिर तक. And it was clear that you needed better understanding and better outcomes for Wilms tumor. It's no longer acceptable कि चलें 25% मरते हैं तो कोई बात नहीं. At that point in the United States, there were 3 or 4 different big groups taking care of children with cancer. There was the Children's Cancer Group, the CALGB, which included lymphomas and other things as well, and then the Southwest Oncology Group. The difficulty with trying to get people who have their own agendas, their own things, to come together and to actually collaborate is massive. But that happened in 1969. 2 moonshots हुए थे 69 में. एक तो एक्चुअल चांद तक पहुंच गए थे, आर्मस्ट्रॉन्ग वगैरह, और एक ये हो गया था. इसके अलावा और कुछ नहीं हुआ था उसमें. So the National Wilms Tumor Study Group was formed. And not only did it include different groups, it included different professions. Can you even imagine? Surgeons, urologists, oncologists, radiation therapists, pathologists, statisticians, इन सबको आपने एक कमरे में बंद कर दिया, and they didn't kill each other. That's a huge thing. And so the purpose of this was not only to just improve understanding and outcomes in treatment, but actually उनके ज़हन में ये था कि this can become a model for how we take care of other cancers, whether it's in children or even in adults. And the rallying cry was, cure is not enough. NWTS के अंदर, there were 5 studies, NWTS 1 through 5. 4 of them were the initial ones. They were randomized controlled trials, and they're still following the long-term effects. NWTS 5 was mostly a biology and other study like that. So abhi tak uske long-term effects follow ho rahe hain. And in 2001, NWTS became a thing of the past because it merged with the Children's Oncology Group, which itself was formed by the CCG and the Paediatric Oncology Group, and it became now the COG Renal Tumor Study Group. What about PSYOP and its relevance to Wilms? तो उसकी कुछ तो बिलाल ने बताई है, but it actually started a couple of years before the folks in the US got together. And there was a group of surgeons, again, pediatricians and pathologists. Most jokes start like this. A surgeon, a pediatrician, and a pathologist walk into a coffee house, और उसके बाद फिर उनकी लड़ाई हो गई. But in Paris, they actually got together and formed a club of people interested in cancer, and especially children with cancer. In 69, उनकी जब third meeting हुई थी, वो मैड्रिड में की थी उन्होंने, and they renamed themselves as PSYOP, क्योंकि फ्रेंच थे तो उन्होंने कहा हम तो फ्रेंच नाम रखेंगे, तो उल्टा सीधा हो गया, मगर उसमें आई बड़ा इंपॉर्टेंट है. The I is critical in this, the international. They also elected a president at that point. और जिस तरह से भी बिलाल ने दिखाया था कि 71 में SIOP 1 was the first trial for Wilms, and they compared neoadjuvant chemo in one arm and then radiation. It was in both arms, studying the role of radiation. Subsequent studies, like Bilal mentioned, looked to avoid radiation or at least the neoadjuvant form of radiation. And then in 1984, the Society Internationale, came up into being, and they were really concerned about global cancer care, and developing nations were invited. ये बड़ा फर्क है COG में, which is very limited to North America, और उनकी दुनिया North America में शुरू होती है और ख़त्म होती है, as opposed to SIOP, where it is truly international. And they did a total of 7 trials. और नंबरिंग उन्होंने पता नहीं किससे की थी, क्या सुबह उठ के उनको ख्याल आया कि आज ये नंबर लेते, बट कोई साइंस होगी इसके पीछे. 1, 2, 5, 6, 9, like iPhones, I think. And then they came up with these 7 trials. And now most places around the world, other than North America, follow SIOP guidelines and the umbrella protocol. So what about survival? अब हम दोनों को कंपेयर कर ही रहे हैं ना. कहानी एक है कि again, people with diverse, completely discrete and backgrounds where they want to protect themselves and who they are got together to actually advance care. तो हुआ क्या? So you can see that the survival both for NWTS and SIOP eventually, especially 9301 को आप देखें, तो they are very similar. And statistically, there is no difference between the two in terms of survival overall or event-free. और अगर आप एक कहानी को देख रहे हैं जो कि 60s में शुरू होती है और अगर हम 2018 तक लेके जाते हैं, so you can see that there has been continued progression. And you can see that initially there was therapies that were added and it went up all the way into the mid 70s, 1980s, 1990s. And then people started really getting concerned, okay, are we doing too much? Because now we're seeing secondary effects, whether that's doxorubicin-associated cardiotoxicity or whether it's delayed cancers such as lymphomas and leukemias that are happening 20 years later. And so then there was a reduction. And now the whole name of the game is reduction in therapy while maintaining this very superb survivals that you can see. Or 2018 में, you had the WHO launch the Global Initiative for Childhood Cancer. More on that in a few minutes. But the rallying cry for us should be the same. Cure is not enough. We need to go beyond that. चलें, अब हमने 2 philosophies की बात की. Right? They're philosophies. One is very surgical oriented, and I am a surgeon, so again, that's my disclosure. And so what is better? Which one should we do? So my own bias was, and to a certain extent has to be, COG. अगर मैं एक stage 1 type किसी lesion को देखूं और मैं कह दूं यार इसको थोड़ा कीमो दे दो, and I'm in the US, they will take away my card कि हाँ आप ऐसा करें, आप वहाँ बैठ जाएं, आप इन पे ऑपरेट नहीं करें तो आपके लिए बेहतर है, हमारे लिए. But when you look at the data and you take your rose-tinted COG glasses off and you compare it with SIOP, you have to be honest. The rupture rate, the tumor rupture rate, is far higher in COG-related studies. And in fact, studies from other parts of the world, like this one from South Africa, showed that stage 4 stage, the overall survival, the rupture rate, everything goes down when you give upfront chemo. Even for stage 1 and 2, जिसको आप कहते हैं कि तो हलवे वाले cases हैं, right? These I can take out with one eye closed and one hand tied behind my back. Yeah, I'm going to take it out, but I'll probably rupture it. So in the UK, I think the evidence that really is the last nail in the coffin for me, at least, is they actually they were kind of a hybrid approach, neither PSYOP nor COG, but they kind of adopted both. And they said, स्टेज 1 to 3 के लिए उनके जो पहले जो विल्म के 2 ट्रायल्स हुए थे, they recommended कि upfront resection आप करें जो अच्छे आसान केसेस होते हैं. But in 2001, they published a decade-long study, the third study, which compared these two over 10 years. And they found the rupture rate was 0% when you gave upfront neoadjuvant chemo, whereas it was about 14.6%, 15% ke kareeb, when you tried to take it out upfront. And then when you look at PSYOP 93, it's the very same data. When you look at COG, if they're being honest, it's the same data. There's about a 10% rupture rate that's reported. And then when you look at the other aspects, there's a reduction in therapy and a more favorable stage shifting when you give neoadjuvant chemotherapy. And 20% of the survivors were therefore spared doxo or radiation. So I think for us, I think when we read that story, I think from a surgical standpoint, it should be clear for us that we need to adopt and follow the PSYOP guidelines. हमारे अपने setting में, the way we've trained, the way we train our surgeons and the way we look at things, in my mind, there is no doubt what we should do. But what do we know from LMICs? So the facts are sobering. Abhi humne baatein ki hain, and I showed you data on survivals that were in the 90% range for stage 1, and even for stage 4, it's above 80%, at least 2-year survival, and if not 5-year survival. But jahan studies aapko hain aapke paas, which is mostly from Africa, the survival ranges from about 11% in Sudan to 46% in Malawi now. It wasn't before, but now. Studies वहाँ बेहतर होती हैं, वहाँ पे पैसे भी ज़्यादा देते हैं, developed countries. Overall, worldwide, there's about 14,000 Wilms cases a year. There's about 5,000 deaths a year. And if you can see the data after that, a vast majority of these deaths occur in LMICs. 50% of kids who have Wilms tumor in LMICs present with metastatic disease, therefore they're stage 4, or at least stage 3. When you look at studies from Kenya that have documented things, the 2-year overall survival in Kenya was 35%. क्यों? So जब उनको details उन्होंने देखे, तो 55% of the families had severe financial issues. This is a country where insurance की जो penetration है, वो about 60% है. We know this because AKU actually has a big presence in Nairobi. उनके 60% जो patients आते हैं, वो they're under government insurance. उसके बावजूद they had a 25% abandonment rate. This is a unique thing LMICs में. अगर अमेरिका में कोई बच्चा मेरे सर्जरी के बाद कीमो के लिए ना आए, हम उसके घर पुलिस भेज देते हैं और वालिदैन से कहते हैं अस्सलाम वालेकुम, ये बच्चा अब आपका नहीं है, ये बच्चा अब स्टेट का है, हम इसको संभालेंगे, इसको कीमो देंगे और फिर आपके पास अगर आपने जज को कन्विंस किया वापस कर देंगे. यहाँ तो 25% अबैंडनमेंट है और वो हम बर्दाश्त करते हैं. 16% were simply lost to follow-up, probably abandonment. And 63% of the families actually indicated कि हमें तो समझ ही नहीं आ रही है, आपने ट्यूमर तो निकाल दिया ना, अब हमें मजीद कीमो या ये शुआएं देने की क्या ज़रूरत है? So that's our fault. We're probably not doing a good job in explaining these things. These 2 studies documented this. One of them is a survey which looked at practices among pediatric surgeons, primarily in Africa, and found those issues you mentioned. The second study actually looked at whatever's been published and also whatever they surveyed again, mostly in African countries. So when they looked at it, this is what the global incidence of Wilm tumors looks like. So you can see that it seems to be much higher in North America, Europe, and Russia than the rest of the world. Why? They have better data. Look at this middle of Africa, the big swath of Africa. खाली पड़ा हुआ है, किसी को पता ही नहीं है. And these are age standardized rates of Wilms tumor. When you look at all the world regions, you can see that overall Wilms tumor की जो component है renal tumors में, it's quite large. But South Asia and Southeast Asia seems very low. Either we are genetically immune or हमारे WT1, WT2, yeah, all of those 11p genes are absent and we're really good, or we really don't know our data. One of those two is true. And then जब आप focus करते हैं हमारे इलाके में, so you can see that Pakistan reports an age standardized rate of about 3.6. I have no idea where we got this rate from, honestly. But India के जो है वो 3.84 के 4.4 है, and then you look at other surrounding areas, they're higher. But then look at all the gray. We have no idea about these other areas. If you look at the incidence rate in 1990 and 2019, there's not much difference except for Mexico, which dropped its rate. Otherwise, it's been pretty stable. But if you look at mortality, remember that swath in Africa, which almost had no data on at least in prevalence? We can know what the survival and death rate is. And you can see mortality is in those areas is very high. Pakistan की mortality जो है वो भी उन्होंने कम दिखाई है. I have no idea where this data came from either. Came from somewhere. So remember we mentioned 2018 May, there was the Global Initiative for Childhood Cancer sponsored by and pushed forth by the WHO. And in this, they said that by 2030, a mere 4 years from now, 5 years from now, that they will be achieving at least a 60% survival rate for all childhood cancer and reduce suffering for all, and essentially save 1 million additional lives. It was great. And how are they going to do that? They're going to do that by increasing the capacity of countries to provide quality services, including surgery, and increase the prioritization at a global and national level. This was implemented across 6 to 10 countries by about 2019 and 2020, and is supposed to be implemented by 18 and 25 countries by 2023. इसमें पाकिस्तान का नाम भी आता है. And they chose 6 cancers. And they chose these 6 because of the prevalence, because of the impact in taking care of them. And you can see one of these 6 is Wilms. And partly Wilms was there because it has the ability to connect multidisciplinary services. And if you can connect multidisciplinary services for Wilms, you can do it for other things as well, certainly other cancers. Here's Pakistan. So Pakistan is listed as one of the countries participating in the initial phases, but उनको अभी तक letter of designation नहीं दी गई है. मिल गई? हो गया? 23 से ये हो गया. So this is old data, but this is what's updated on the Cure-All website. अब हम पाकिस्तान पे आते हैं. So what is the extent of the issue in Pakistan? I will humbly suggest to you that we really don't have the data. Despite the maps showing an ASR of around 3.6, I am totally unclear as to what true on-the-ground data this is actually based on. The good thing is that there is a number of single center publications over the past 5 years or so that have helped us in understanding कि मसला है कितना गंभीर और how are we doing, at least in the very super short term. And early outcomes, समझ लें कि survival to discharge का कुछ data है हमारे पास, but 2-year outcomes, 5-year outcomes, which for cancer, and I don't have to convince anybody in this room, that's what matters. We really have skeletal data on that. What about following protocol for surgery? Let's come to surgery for a second. So the protocol for surgery requires us to take out that lymph node packet. It's not a lymph node resection, it's lymph node sampling. Adequate lymph node sampling for us is 2 to 8 nodes. And that includes not just the surgeon, but your pathologist. So I recently took out a whole sample of the para-aortic and paracaval nodes, sent them as a separate specimen, and we could at least see 6 or 7 nodes, and I was happy कि चलो मेरा number तो इसमें हो जाएगा. Plus, if they take the stuff that's in the renal hilum, 10-20 तो हो ही जाएंगे nodes. They found 1 node. I'm like, are you serious? Did you stop looking after you saw the first one? How did you do that? So I think we have to really follow the protocol. We also have to follow the protocol and timing of surgery. Let's face it, we should not be operating on these kids before they get chemo, and we need to operate on them after they get the 4 weeks of chemo, and we have a very limited timeline where we can do it. Otherwise, they need another round of chemo. And we've talked about how many radiation units there are, so there's not much. So the more we can save radiation for these kids, the better we're going to be. So here's some stuff that's come out of Pakistan. Just this is the last 5 years. Agar maine aapka paper nahi isme dala, to meri mazarat, but this is what I could find. We have stuff that came out from Indus. We have studies which have looked at histology patterns, looking at early outcomes, and a lot of them, this study is very honest, in which, again, the Shaukat Khanum ka hi hai, we're at least saying early outcomes, right? We're not looking at 2-year, 5-year survival because वो data नहीं है हमारे पास properly. And then we're looking at how accurate radiology is in detecting this and figuring that out. One study from AKU, which looked at their registry and tried to look at quality of treatment and survival. Now, I looked at this registry too, and you would think कि AKU के पास तो सारा data होगा, जितने उन्होंने कम से कम, however many kids we took care of, we'll have 2-year and 5-year. No, we don't. We do not. And then you have studies that have come from other centers like Pindi and Lahore and others, which have looked at the effects of chemotherapy, the predictors of treatment outcome. No surprise, again, it's important that we document it, but we also should not be surprised at the higher stage and the more malnourished and the more problematic patients we have, the less likelihood that we have for them to survive. So there's some stuff, and there's hope, because the PSPO, the Pakistan Society of Pediatric Oncology, in the last few years did come up with a national standard of care protocol under the stalwart folks who managed to put forth in that. There's people who are here who are surgeons, radiation oncologists, pathologists, the same group that we saw in the initial 60s, जो विल्म्स के लिए उन्होंने NWTST में डाला था. So we have started the work, but what are the issues that we continue to face? We still face issues with awareness. Both public, pediatricians, even us surgeons, we still will say कि यार ये तो बड़ा आसान है, ये मुझे करने दें. Right? I mean, I get it, I understand, सब साथी हैं हम, but we shouldn't do that. We have no data, let's face it. We have no databases. We don't understand the prevalence. We don't even know our short or long-term outcomes. And without doing this, we're blind. We have to understand that. We have the poverty and financial issues, and that's a government issue. We need to petition the government that cancer is important. और cure all वगैरह में यही था कि आप next stage में governmental funds ही लेके आएंगे ना करने के लिए. आसमान से नहीं आएंगे ये चीजें. So human resources, do we have enough oncologists? We look at this room, we'd say, yeah, we probably do, but we don't. We don't have enough surgeons, especially those who are trained in terms of doing the resection for this. Oh, I've already done my time. मेरा भी slide अभी kill switch आने वाला है. So what are the potential solutions? We talked about the cure-all in childhood cancer, and the collaborative outcome project in Wilms in the Malawi jo hua tha, that's a roadmap for us. Why? They took the survival from 25% to 46% in less than a decade. They doubled it. We can do the same if we just have the data. And if we put collaborative registries together with just the people sitting in this room, and we plan to say that every patient with Wilms will be enrolled in that, we can do it. So to summarize, we discussed the Wilms and the history of COG and PSYOP. We discussed the similarities and differences between them. We then focused on issues that LMICs and in particular Pakistan face. And then we briefly mentioned a way forward, which primarily means putting us all in a room together, throwing the key away, and until we come up with a way to collaborate, don't open the door. Because this question is very valid for us. आप कहते हैं कि ठीक है डब्बे को लात मार के आगे भेज दें, हमारी next generation करेगी. We can't do that. So we really need to say that if not us, who? And if not now, then when? Thank you.
Thank you so much, Dr. Salim, for finishing your talk on time. So we are moving to our last talk of this session. So it's my privilege to introduce Dr. Filippo. He is a pediatric oncologist at Pediatric Oncology Unit of the Fondazione IRCCS in Milan, Italy. He has a special interest in pediatric renal tumors with more than 230 publications in his credit. He is talking about research on relapsed brain tumor.
First of all, let me thank you so much for this kind invitation. I'm so glad to share with you, of course, on one of my favorite topic. It is to talk about relapse Vince tumor. Here is my email address. Feel free to use it in case you want to share cases, you want to ask me any questions in the next days. So first of all, I think that you should ask me, why do you think it is so important to talk about relapse in the context of pediatric oncology, and even in the context of low or middle income countries where resources are limited? You know, the answer is because in this view, Vim's tumor has a unique characteristic among pediatric oncology. It is patients suffering from relapse can still be cured in a significant proportion of patients. And there are different reasons to explain this. One main reason is that most of children treated for Vince tumor are currently treated all over the world with a minimal primary treatment consisting on vincristine and actinomycin in approximately 2/4 of children. So that means that we have other opportunities, other drugs, other weapons to use at relapse. But there is one thing that we need to keep in mind, that there is a strong relation between initial treatment in terms reflecting the biology of tumor and the chance to be cured relapse. In this symbol, I just want to represent that in those patients with a high risk characteristics of Vim's tumor, like those with diffuse anaplasia or the blastemal type after preoperative chemotherapy, who are receiving upfront very intensive treatment, they have this small survival at relapse. But on the other hand, those patients initially treated for a low or intermediate risk tumor with a minimum to drug and no radiation therapy treatment, they have a significant chance to be cured. Well, when we started a few years ago to think about the current relapse recommendations in the SIOP renal tumor study group umbrella protocol, we decided and we had clear in mind that you need to start classifying patients into homogeneous groups of risk. And in this view, we divided patients into the so-called AA, BB, and CC group corresponding to standard high and very high risk. And the main stratification factor was, as I was saying, the treatment initially received. So now in the current classification of relapse Vim's tumor patients inside umbrella protocol, we have the AA group, that is patients initially treated with only 2 drugs. Then the BB group, patients initially treated with at least 3 drugs, so vincristine, actinomycin D, doxor, and most of them radiation therapy. And then we have the CC group, patients initially treated with almost all the drugs that we use in Vim's tumor because of high risk disease. And it's important to have clear in your mind this stratification because these patients have related expected post-relapse heaven-free survival in different ranges. And that means that if you want to decide how to allocate resources and if you want to see which are the clinical and the research needs of a patient's relapse, you need to be aware of these classifications. So what we did, so you have to know that when we decided to design the current umbrella recommendation at relapse a few years ago, actually we had a low level of evidence because as you know, as you may know, we have scanty information on homogeneous large casuistics of patients tradedly homogeneous at relapse. So this is the reason why in the past 2-3 years, we did a lot of effort to try to retrospectively analyze a large group of patients treated for a relapsed Wilms tumor within the previous SIOP protocol, SIOP 9301, SIOP 2001, and also the UK input study. So what we did, well, first of all, we did retrospectively analyze patients treated for an AA relapse. We had the chance to look at 109 patients, and we had some research questions to ask. First of all, we wanted to describe which is the expected heaven-free survival. Then another important question was, we know that the current recommendations are based on a rather intensive chemotherapy rescue approach with cyclophosphamide, carboplatin glucoside, but we were aware that there were some centers who did treat again patients with a less intensive treatments, increasing actinium and doxorubicin. So which is the survival? Then we wanted to know among the alkylated agents if there was one more efficient. And the third question, last but not least, whether the role of high dose chemotherapy in the context of AA. So first of all, expected heaven-free survival is in the range of 70% and the overall survival 79%. So this is the picture of survival we need to compare in the future for AA patients. First questions, what about those patients that in some centers have been treated with a less intensive treatments? They did not that bad. 80% in patients retreated at relapse with just 3 drugs. But just be aware that this is a retrospective study. So we cannot exclude that those patients who were treated with a less intensive treatment, they had more favorable prognostic indicators. Then questions about alkylator. No difference between patients treated with a high phosphonate-based regimen comparing to those treated with a cyclophosphamide-based regimen. And what about the rule of high dose chemotherapy? I want to be very clear. There is no benefit to use high dose chemotherapy in the context of AA relapse. So patients initially treated with only vincristine and actinium, there's no rule to use high dose chemotherapy and bone marrow transplantation at relapse. So what we can summarize in our analysis on AA, first of all, it is important to have guidelines because if we do not have guidelines, as you can see in the past, patients were treated very heterogeneous, many different treatments. We can conclude that in the future, we need some research because there is luckily a subgroup of patients with AA characteristics, maybe with some more favorable prognostic indicators who can be treated with a less intensive treatment. And then another concluding remark is that high-dose chemotherapy has no rule, and as far as the best alkylating agents, we do not have enough evidence to say that high phosphamide is better than cyclophosphamide. Then we did also more recently, this has been recently published in Urology Oncology. We did a similar analysis, but on patients treated for a BB relapse. Just to remind you, BB means patients initially treated with at least 3 drugs. And the CC patients, CC means very high risk patients initially treated with many drugs because of a diffuse anaplastic or blastema type tumors. Again, we had the chance to retrospectively analyze patients treated in the previous SIOP protocol, and which were our research questions. First of all, again, we wanted to describe survivals for the BB and the CC, which is the expected survivals. The second point, we know that many patients are currently treated with an HICE, ifosfamide, carboplatin, etoposide, or CCG, cyclophosphamide, carboplatin, etoposide-based regimen, but more recently also a camptothecin-containing regimen, irinotecan or topotecan, have been more recently introduced. So this is one question. And the third question again, what about the rule of high-dose chemotherapy? So first of all, as you can see in this picture with Kaplan-Meier survival curves, expected event-free survival and overall survival for patients treated for a BB relapse is in the range of 60 to 65%, which is not that bad. But on the other hand, patients treated at relapse for a CC risk group relapse, we have a small prognosis with a survival rate which is largely below 20%. So what about the question on, let's say, the better backbone regimen? If we look at BB patients, we can see here that a combination of HICE and CCE was better than a combination including irinotecan or topotecan. So the better event-free survival and overall survival. But I want to be very clear that this was not a randomized study, that was a retrospective analysis of patients treated just with recommendation across centers, across countries. Be aware of that. This was similar also in the context of CC patients. So also in CC patients, to use again a sort of combination with HICE, cyclophosphamide, carboplatin seems to be effective. And what about the rule of high-dose chemotherapy? This is in line with the previous reports, previous analysis. I have to say that we need to be aware that so far we never had the chance to evaluate the benefit of high-dose chemotherapy with a randomized trial. So this is important to say. In the context of a retrospective analysis, we can say that the use of a high-dose chemotherapy to consolidate a good remission in the context of BB had some benefit. So what we can share about the BB and the CC group thanks to our retrospective study. First of all, that the expected survival for the BB is in the range of 60%. So we need to be aware that we can still have some chance to rescue patients relapsing with the BB characteristics. But this is not the same for the CC. Then we also need to be to remark that an HICE CCE backbone can be regarded as the standard cornerstone of treatment for BB, and I would say also some CC patients. So I have to say that this was important to reinforce our knowledge in saying that HICE and CCE is a good standard backbone of treatment had relapse. I don't want to say that this is better than in irinotecan-based treatment because we never compare in a randomized patient. So I think that in the future, we need to put some researches try to see whether high CCE is superimposable to like VIP, the increasing irinotecan temozolomide. So taking into consideration the results, the findings from these two retrospective recently published papers from the SIOP for the AA-BPHC, I can tell you that this is like, this is how the current treatment stratifications and related treatment recommendation looks like within the SIOP umbrella group. So we have three groups of patients at risk groups of patients that relapse, AA, BB, and C. For the AA, I can tell you that the current backbone of drugs with cyclophosphamide, drugs releasing carboplatin deposit is a good option. In the future, I think that we are going to see whether there is a subgroup of patients that can be treated with a less intensive treatment. Then we have the BB group, for which we have an expected heaven-free survival in the range of 60% with a standard backbone mainly based on HICE and CCE. In the future, we need to see whether irinotecan is a good drug to incorporate. And to the best of our knowledge, in those patients with a very good response to a reduction phase, high-dose chemotherapy is going to have something. Then we have the CC patients, so patients initially treated for a diffuse anaplastic venous tumor, for a blastomal type venous tumors, advanced stage 3 and 4. Unfortunately, for those patients, the chance to be rescued at relapse is very low, and I cannot say that we have a standard of care. In the context of the SIOP, we are looking for new drug for this group of patients because we have seen that the expected survival is less than 20%. So let me conclude with few considerations as far as, so what we have said so far is that the presence of diffuse anaplasia is the leading cause of death in venous tumor because patients with a relapsed diffuse anaplastic, advanced stage or metastatic venous tumor has virtually no chance to be cured. So why anaplasia is so difficult to treat? Because, and this is a paper we have recently published with the collaboration of the University of Lund, the main driver of the biological aggressiveness of anaplastic tumors is that thanks or due to p53 mutation, diffuse anaplastic tumors are able to replicate regardless of DNA breakage. So that means that if we want and if we use those drugs that need p53 integrity to act, like most of the classical drugs, we are going to fail. That means that if p53 mutated anaplastic venous tumor cells are going to replicate regardless of DNA breakage, we need to use drugs who are effective like vaccines without p53 mediated apoptosis. So in the future, I think that we need to look at this class of drugs like the vaccines. So let me conclude with a special acknowledgement to all of my colleagues of the SIOP renal tumor study group, and especially those involved in the relapse committee. So thank you very much also to you for listening to me and for this kind invitation.
I think this finishes our invited talks. Now we move to the panel discussion. And for panel discussion, we have panelists Dr. Salim Islam, Dr. Bilal Mazhar Qureshi, and Dr. Filippo.
The house is open for the questions. Any questions from the audience?
Okay, so I can ask the first question for Bilal. Assalamu alaikum. I'm Halima Said, pediatric oncologist at Shaukat Khanum. We worry so much about the timing of radiation, and that's like a ongoing battle getting that done in time within the 2 weeks after surgery, and almost never seems to happen. Is there, and then we have that group that needs pulmonary radiation that we say it's okay to do it at week 10. And is the data showing outcome in local relapse comparing those two groups? The ones that got it at week 10 versus those that we somehow got into those 2 weeks. Like, is it okay to just give it later and, chase other things other than the timing of radiation? Like, is there data to support the need for the 2 weeks?
Dr. Halima, logically very nice question and very pertinent thing, but I do not know if there is any comparison data to already publish that compares the outcome of those two groups. I'm not aware of that data, but it's just the way the yeah. So it's so
This challenge, because this is the big challenge. And actually, the oncologist is also not sure when to give the radiotherapy. And knowing that we don't have the radiotherapy slots for our kids in time. So what are your suggestions and two guidelines for us?
So I think Dr. Alia, no one can guess, or no surgeon would say that, hey, I'm going to spill this tumor, so get ready to start radiation immediately. So that's not going to happen. But if there are like things like that, just like me and Dr. Salim had a case where we knew preoperatively when we saw the images, at least I saw those images in after the surgery was already done, that there was already spillage present preoperatively. So in those kind of cases where you know that there is indication for whole abdominal radiation immediately after, it's best to coordinate with the radiation oncologist before surgery is done, or at least immediately after surgeries, so that they can plan things ahead of time. Obviously, but this single thing is not going to solve the problem. You need to involve the radiation oncologist in your multidisciplinary team. And we have that example within Karachi that Indus Hospital patients come to us and we have regular MDT and connections. So even if it is not under one roof, it can still work out. And the third thing that I would try to tell you is that there are other issues as well, except the radiation waiting list, the post-operative wound infections may happen. I do not have data to quote or to accuse anyone that post-operatively infections happen, but then histopathology reporting and all those things are very important. You cannot just go ahead and start radiation therapy without knowing the risk stratification. So there are a lot of challenges with that too. But I think need for MDT is the basic thing. Dr. Najma.
My question, is there any role of SRS or stereotactic radiation in relapse setting when there is a single kidney?
No, I'm not aware of that. The most modern thing that is being used is conformal treatment planning with VMAT, that I showed from the Utrecht group in Europe, Princess Maxima. They are not using hypofractionated radiosurgery or stereotactic setup for those patients, and still even that strategy of highly conformal radiation therapy is not part of the SIOP protocol. It's allowed within the protocol that some centers use it. Still, a lot of centers, most of the UK centers do not follow highly conformal. They are still doing APPA, and same for COG. They are also still doing APPA as part of the even at places like MD Anderson and Emory.
So yeah, it's a real challenge for both for relapsed Wilms tumor, if they relapse in the remaining kidney, or in patient bilateral Wilms tumor, if one-sided nephrectomy has been done and the other side lesion is not resectable, then it's really challenging to manage these patients. As in our limited resources, it's very difficult to go for bilateral nephrectomies and then dialysis or transplant.
Yeah, I believe Dr. Akila, we have very specific guidance on managing bilateral Wilms tumor now in RTSD as well as the COG protocol on how to do local treatment. There are guidelines for nephron sparing surgery, how to deal with both the kidneys together or in separate setting through stage resection and so on. And even if one-sided nephrectomy is done and second-sided enucleation is done with positive margin, which is coming out to be uh, a stage 3 because of positive margin. There is guidance within the Wilms tumor RTSG protocol on how to irradiate. Radiation therapy is not an absolute contraindication in that situation too.
Thank you. And one more question. For those patients who need abdominal radiation, how much is the risk to the normal kidney to get radiation nephritis in long term? And is there any way it could be prevented?
Yes, so whenever you are doing whole abdominal radiation therapy, I did not go into the detail, but conventionally, when APPA fields were used, if a dose would be according to risk stratification more than 10 or 12 gray, a midline block used to be introduced, which could shield the kidney at its tolerance doses. Now that we have data from Pentec group, Pentec is pediatric late effects after radiation therapy in clinic, led by Dr. Sandy Constein in Rochester, and I'm part of the renal tumor paper on that. So there is guidance of tolerance of kidney, which comes from the TBI data. So the tolerance is 10 to 12 gray. And with volumetric modulated ARC therapy, it's possible to spare the kidney to that dose. So whole abdominal radiation therapy does not mean that you are going to blast off that remaining kidney, but there's a way to protect that according to the known tolerance limits.
Thank you.
So we have Dr. Filippo online. So any question from him?
So I do have a question from the pediatric surgeons. So we are doing a Wilms tumor surgery in a centers in which the surgeons are trained to do an oncology surgery. But then again, there are those pediatric surgeons who probably don't do it up to the standard, up to the mark, because I am practicing in Peshawar and I've faced cases in which, in fact, in Lahore, we actually see the cases in which they don't do the lymph node sampling. We're not sure about the tumor spillage. So what should be the approach? Do we automatically upstage our chemotherapy and our treatment plan? Because we don't know, we don't have a proper histopathology.
Yeah, so those are three things. One is being honest about tumor spillage. Two is actually doing an adequate operation, which has to include nodal sampling. And three is operative notes. So for operative notes, this is a worldwide phenomenon, by the way. So even though you're facing this in Peshawar or Lahore or Karachi, this is a worldwide phenomenon. So the COG actually introduced standardized operative notes for all Wilms tumors, especially, but also for neuroblastomas and other tumors as well. For Wilms tumors, they've specified you have to tell whether there was tumor spill or not. You have to document the nodal resection and how many kind of areas that you sampled. And then you also have to document certain other things. And because the electronic medical record in the US is so ubiquitous, they basically have included it in the major EMR, which is Epic, and so we'll include OGA. So we can introduce that here by creating a standardized operative note for all patients with Wilms tumors that has to be filled. It'll do two things. It'll go to the second point, which is if the standardized operative note is demanding that I state which nodal area did I sample, I'll probably have to actually sample. let's assume that no one's lying and no one's deliberately fudging the truth. Let's just assume that. So it'll remind me and encourage me that I have to do that. Second, the final thing is the introduction of the whole thing about spill or no spill. So NWTS4 actually looked at patients who were classified, because they classified it in NWTS as diffuse or local spill. So they tried to differentiate that. So that local spill, that will require only flank radiation, whereas diffuse spill will require abdominal radiation. So what did they find? And these are surgeons in the US and Canada. They found that kids who got just flank radiation had a poorer outcome than those who had total abdominal radiation, which is absolutely the opposite of what you'd expect. Because those who had diffuse spill, you'd expect them to have a worse tumor, and therefore you spilled more and you'd have a worse outcome. So what it turned out was that surgeons were not being truthful. And that our egos prevented us from actually saying that this wasn't just a regional spill or just a local spill. This was in fact diffuse, and so they eliminated that from NWTS and COG. All spills are diffuse. All spills get complete abdominal radiation. I mean, overall survival was better. So what we can do in terms of trying to do that is, again, the standardized operative note, which has all of these elements in there. They have to be documented. Let's assume that honesty will be there. Nodal, we just have to keep pushing that. Every meeting that we have, every group that we have. So we had the PSPO meeting last year, and I talked about the fact that we need to have a nodal dissection in each case, whether it's upfront resection, which we don't do here and we should not do here, or it's post chemo. And so we just need to keep hammering away at that. And then we have to improve the education from a surgical standpoint.
I think Dr. Filippo is online. Dr. Filippo, can you hear us?
Yes, I can.
Yeah, you wanted
you
to
hear
add
me?
something?
Yes, thank you. First of all, I just would like to thank you for inviting
Your
me. I'm
voice
sorry.
is not clear. Your voice is not clear.
You can hear me?
Yes, we can now.
You can hear?
Just repeat the
Maybe,
question.
maybe there is
Yes,
some delay in the connection. So first of all, thank you so much for giving me this opportunity to be with you. I'm sorry I could not attend in person. No, just want to add that the issue of not sampling, of missing sampling lymph node is a worldwide issue. It's not only a matter of middle-income countries, it's something we are struggling also in Europe. I have experience in Italy as well. And the question on what to do if you do not have any information on lymph node. So we have to upstage the tumor, you have to uptrade is really the most important one, because actually at the moment we do not have worldwide straightforward data saying that if you miss lymph node, you need to upstage the tumor. We used to have some data from the National Lymph Tumor Study say that missing to sample lymph node is a negative prognostic factor. But recently, I had the chance to discuss within the ARIA initiative, the Adapted Treatment Regimen Guidelines supported by St. Jude. I had recently the chance to discuss with Dr. Jeff Dom from COG, who presented very recently data on missing lymph node. And actually, it doesn't reach a significant difference in reducing event-free survival. That does not mean that we can avoid sampling lymph node. I don't want to be misunderstood. It's so much important, as my previous colleagues say, but the point is that we do not have a clear answer to the questions what to do if we do not have a lymph node. We are now approaching a Delphi methodology question, try to see which is the expert opinion about that.
Thank you, Dr. Filippo. I would like to agree with that. And just a comment on what was asked previously about the spillage and the focal thing. I think for all practical purpose and for our patients and to make realistic real world decision, we need to be a bit more inquisitive during our tumor board discussions or whenever we have a conversation about each patient regarding the surgical field. So through our experience, what we learned is that uh, you do need to be inquisitive and provocative in tumor board. Like when a surgeon says, "Hey, yeah, it was only a local spill." Yes, it was, but what did you do after that? The surgeon will say, "No, no, it was a very small window." And then what did you do? And when he explored the surgical node, and then we have washed the whole abdomen. So that would mean that the whole abdomen is now at rest, whatever sterilizing material you used to wash it. And that has been changing our decision to move from only flank radiation therapy to whole abdominal radiation therapy through those discussions. And same for other practical decisions in radiation therapy, all of the conformal radiation therapy work that is being published and maybe followed very by many colleagues if they have BMAT or access to technology and anesthesia and sedation. But what's very important for highly conformal radiation therapy is to know where the adhesions were present, how the surgeon documented that, and where the clips was produced and placed. And similarly for the decision, like where the tumor was adherent to the diaphragm or not. So the radiation oncologists and the pediatric oncologists need to be very much aware of what happens in surgery.
Yep.
And then apart from the COG paper, we do have published recommendations about synoptic reporting of surgical notes for different tumors, including sarcomas and neuroblastoma. And well, there's a specific paper on WILMS on how surgical finding impact the adjuvant treatment and decision making, and then how it impacts for other tumors as well. So that's already published, and I think we should follow those recommendations.
So, I mean, communication is key. I think if you're in a center where you only have 2 surgeons, or let's say 1 surgeon, you don't have a choice. But in most centers, so I think Dr. Filippo mentioned that even in Europe, they have nodal issues. The same thing is in the US. There's the biggest single protocol violation is lack of nodal sampling. But what they've done over there is there's some degree of regionalization. In Europe, regionalization is far more advanced, at least in the UK, it's far more advanced. So they will send them to centers where they specialize in that care, whether it's biliary atresia or in this case, oncologic procedures. In the US, they've done it so that if there are centers where there's more than 5, 6, or 7 surgeons, the oncologic procedures will be given to 1 or 2 of them. And so I would say that if you are in a center where you have a fair number of pediatric surgeons, maybe within the group you can decide that this individual or these individuals are going to do the oncologic or cancer surgery. And you can even divide that if you want, where the hepatoblastomas will be done by a certain individual and the nephroblastomas or WILMs will be done by a certain other individual. That's going to help in your lack of protocol violation, better communication, and then asking those questions. I think you're right. You have to just ask the question, what happened with the spill? And just kind of move from there.
So absolutely,
And-
you have pointedly righted that basically the point is multidisciplinary approach has improved all these communications. So we are working hard for last many years for improving the communication and working on this, at least on this focal point that as the operative notes by the surgeons as well as the sampling. So a little bit we have improved over all these things and they are now doing the lymph node sampling, but still we do have these issues. So the only thing is the MDT and the better communication with the surgeons.
But
actually.
pathology comes into it as well.
Yeah.
Like I said, for the last one that this is just an N of 1, of course, but it's an example. And so we sent that tissue. I saw the nodes that we were taking out. And so if the pathologist is not involved, so maybe at centers, and again, pathology is even more difficult because you hardly have really great pathologists at most centers. They're tough to come by. Maybe have the pathology go to specialized people as well. So in the US for neuroblastoma, Shimada still reads a majority of the neuroblastomas. The guy who defined Shimada criteria, I think he was still alive last time I checked. For Wilms, all tumors go to Elizabeth Perlman, or they did go to Liz Perlman, who was at CHOP. And we had a 10-day window that before you needed it, because we had no neoadjuvant chemo in the US, you had a 10 to 14-day window before starting chemo that Liz Perlman would be able to say, yep, I agree with the local pathologist, or no, I see some anaplastic areas, and so you need to upstage it. Plus, you have to wait for LOH findings as well anyway in the US, which takes about 7 days. And so I think these things, so having a central pathology, that's something that should be considered. There's central radiology, for example, for hepatoblastomas in the US, because these are complex things and they're rare things. To expect everybody to do everything everywhere is unreasonable, in all honesty. So we need to pool our resources on a national level.
Yes, absolutely.
Thank you. Just to add few things. When we started in Shaukat Khanum, we faced similar problems, but when the things were highlighted in MDT, now we follow a standard protocol of notes writing, and we separately send the sample of notes. And the same thing happened with us, that we sent 7, 8 notes and turned out that there are only 1 or 2. Now we write the count in the notes as well. That 7 notes were taken and they were sent separately. And addressing Dr. Palvisha's question, it's a very pertinent question that we have been facing not only in Wilms tumor, but also in cases of Burkitt's lymphoma, where we are having massive resections and patient coming with ileostomies and burst abdomen, which were never required actually. So I think we need, as pediatric surgeons, we need to develop an awareness that these children cannot be treated like other pediatric surgical diseases. They need specialized care and they need specialized training. That's why we need few of the workshops, and we need to train the trainers as well. And I think the one thing which we can do is to introduce pediatric oncology surgery in our fellowship programs separately, so that right from the beginning, this thing is inculcated in the mind of the trainee, that these patients should be treated in a separate way, not like if you are going to treat an esophageal atresia or an appendix or something like that. I think more of the workshops and awareness is definitely needed in our pediatric surgical group. And where I think in our annual conference, which is coming up, I think we need to discuss these things as well. And we should need to collaborate with PSPO as well. I don't think there are much of pediatric surgeons in those PSPO organization as well. And until unless we talk to each other, we will not learn from each other. We should not be sitting in silos separately and doing things that I'm the wonderful surgeon and he's not doing well. That is not on actually. We need to collaborate with each other and we need to learn from each other. Thank you.
But we are wonderful surgeons.
There is no doubt in it.
And a question for Dr. But a question for Dr. Filippo. Halima Saeed, the pediatric oncologist at Shaukat Khanum Hospital. In the relapse setting, what is the outcome for patients that have unresectable masses? Because we use the chemotherapy, but at the end of 4 cycles, we either have a abdominal mass or a pulmonary met that's not resectable. Should those patients be palliated at that point, or what is the outcome that you see for unresectable relapse disease? And my second question, I'll just ask them both so that you can address them, is with the toxicity and the high burden on resources with ice size, because we've been using that for that BB group, but we see very high rate of complications, mortality, and long inpatient stays. And based on the data that you showed, VIT is not performing too poorly. So for a LMIC, would you recommend VIT for, or just VI for that BB group? In
Thank you
terms of
for
being able to give it outpatient and less toxicity?
Yes, thank you. Those are two key questions. Really, thank you for asking those questions. Well, as far as the first one, one of the aspect is that information that we have as far as surgery, but also radiation therapy at relapse are somehow less consistent than the information that we have from primary disease. So having said that, in the very last analysis, retrospective analysis that we could do, and we recently published, those patients who could have a complete resection of the relapsing tumor, as you were mentioning, had a significantly better heaven-free survival than those patients without any surgery. So I can confirm that if you have an operable relapse, the prognosis is far better. In this setting, I would not say that you need to pass through palliation in the case you still have a relapse not amenable to surgery. You can still go to radiation therapy. So the point is that local treatment is essential. First is to discuss about surgery, because then you will have some information also as far as histology or in high-income countries, molecular biology at relapse. But then if the surgeon cannot remove the relapse, you still need to go to radiation therapy first. As far as the second question, I fully agree that toxicity related to ICE treatment is a relevant burden. But I can tell you that we recently had a meeting after SIOP just 2 days ago with the SIOP renal tumor study group discussing about relapse treatment. But I have to tell you that from all the information, all the retrospective analysis that we have, the ICE backbone is far the best treatment option that we have so far. So we analyze retrospective casuistics from SIOP 2001. We are taking into consideration patients treated under the new umbrella protocol, and the highest chemotherapy backbone is the better one. We have very few data as far as VIT, which is not that bad, but we never compared ICE to VIT. So I cannot tell you that VIT is a good alternative. Maybe yes, but we still do not have consistent results to support to choose VIT instead of ICE. One advice I can tell you is that maybe we have experiences that CC, so to replace cyclophosphamide instead of ifosfamide, together with carboplatin and etoposide, as a better toxicity profile to the kidney. So maybe one option is to base your choice on CC, so cyclophosphamide, carboplatin, etoposide, instead of the traditional, the conventional ICE.
I have a question for Dr. Bilal. So this is Dr. Munib, consultant radiation oncologist at Shaukat Khanum. I have a question and a comment. So Dr. Bilal, thank you for the talk. And you just showed regarding the conformal radiotherapy for the Wilms tumor, which is more like a new advanced form compared to the APPA and the whole flank radiation. Could you please emphasize that in which patients we could implement that conformal sparing, whole flank sparing technique in our patient? The other comment is like we were talking about the separate training for the pediatric surgery, and just like we have a pediatric oncology, same goes for pediatric radiotherapy. We need not all the adult radiation oncologists could treat the pediatric cancer, so we should dedicate. So please comment on that, Dr. Bilal.
So thank you, Mani, for this very pertinent and practical question. First of all, I think it should not be a case-to-case decision making. It has to be a standardized approach that you either shift towards highly conformal radiation therapy, keep on following your patients on that and see the relapse pattern, or you stick to the PSYOP recommendation RTSG and then see when the data comes up, then only you could uh, evolve into that practice or delve into that practice. The second thing is very important to understand that the highly conformal radiation therapy recommendations are based upon certain baseline standards. One of them is adequate pre-operative imaging after chemotherapy as well as the pre-chemotherapy imaging and adequate histopathology reporting and the stratification and all those things according to the protocol. And obviously, most important thing is your surgical finding. If you are not in direct, if I am not in contact directly with the surgeon, I am not aware what the surgeon did, uh, where the clips are placed precisely at every margin of adhesion or approximation of the tumor towards the abdominal wall, medially, laterally, the location of the lymph nodes, I would not recommend anyone doing a highly conformal radiation therapy planning. The second thing, again, as I mentioned, that pediatric radiation therapy, just like you would not ask a neurosurgeon to open the abdomen just because he has a theater, he has knives, and he has anesthesia support. Pediatric radiation therapy is a dedicated expertise. Just availability of machine or planning software does not qualify someone to do radiation therapy. Radiation therapy is not like CT and MRI scan that you send the patient to a facility that, hey, it's your time to get radiation therapy, and you expect the patient to come back in 2 weeks or 3 weeks with a radiation report. It's not like that. It's a dedicated specialty. We do lack expertise in the country, but then what I envision and our team envision is to have at least at least two people at every major centers allied or attached to the pediatric oncology center who could liaison with other peers in the country. And that's not just restricted to the pediatric radiation oncologist or the radiation oncologist. It's also restricted. It also involves the medical physicist who plans the treatment because the doses, the target coverage principles, and the sparing of normal tissue is very different from those of adults. The principles are totally different. And the same for radiation therapy technologies because the immobilization devices and the techniques are different. So there are a lot of challenges related to that, and hopefully through ProperNet, we may be able to solve that. Just with the permission of chair, since Dr. Salim talked about the WHO GICC thing and where Pakistan is on that arena, I would just request if someone from PSPO could explain what is our involvement so that everyone knows about it. So because we are far ahead on what Dr. Salim showed on in those slides. So maybe Dr. Alia, you could say that.
अस्सलाम वालेकुम डॉक्टर तारिक गफूर नहीं है अभी सर अगर वो होते सर आप बता दें मैं थोड़ा सा शुरू कर देती हूँ सर उसको कर देंगे एंडोर्स कर देंगे WHO GACC फोकस कंट्री जब ऑफर हुई थी दैट वाज 2022
Dr. Ali, can you speak in English?
Oh, sorry.
We have a guest.
Yes, yes. So actually, from 2022, it was offered to Pakistan, and Ministry of Health. It took 1 year to retrieve that letter of offer from the ministry, and then 2023 we had national stakeholder workshop where Dr. Carlos Rodrigo Galindo and his team came from St. Jude to visit us in Islamabad, and we had a very good national stakeholder workshop, and we explored the GICC activities, what we should do and how to engage the stakeholders. And after that, we are in touch with Ministry of Health in Islamabad, WHO Pakistan, WHO EMRO country offices, and we are doing we are trying to do the work on the core projects, which are the 10 core projects based on the Cure All framework that is C for Centers of Excellence, U for Universal Health Coverage, regimens, protocols already in the CTU of PSPU, we are working, you have seen in the slides. And then the E is evaluation and monitoring. And Dr. Lina, if he's here, she has secured a grant from PARC COP, and we are working on interlinking of hospital-based cancer registries. And inshallah, these interlinking will be linked with National Institute of Health Islamabad, and we will be, inshallah, will be proceeding towards National Country Dashboard for Childhood Cancer, inshallah, because this is one of the core project of GICC activities. And then we are in touch, PSPO is in touch with the Ministry of Health and WHO and other, and of course, St. Jude Global is our key pillar. And we are working for financing and governance, and we are planning for writing up the National Cancer Control Plan. And for that, we are in a process of doing national stakeholder workshops. These are, I think, few things. We are, for all 10 projects, and medication, we forgot. GPSECM is providing free medicine to children with cancer in developing countries, and Pakistan has been chosen. Alhamdulillah, that is a big achievement for us, because initially they chose small countries because they wanted to start slow and from smaller countries, but they took Pakistan as example because they wanted to try a big country, because we are having 10 to 12,000 new childhood cancer cases. So for us, it's a great responsibility for PSPO and local stakeholders also, that we make this project successful, and Q1 or Q2, we will be getting free medicine for Pakistani children, inshallah. So these are.
Okay, thank you, Dr. Alia.
And so many others, thank you.
Dr. Tariq, if you want to add something to this, so otherwise we'll take the last question after this.
Thank you. Basically, Dr. Alia covered very well. So with the GICC, protocols have been made, and 6 of the major treatment, they are locally national based protocols are already in place, and probably data for the ALL has been completed, and we are near to complete the data for Hodgkin lymphoma, and second is the retinoblastoma. And probably by the end of this year, we will be analyzing what we have achieved with the change of these protocols. The second thing is the availability of medicines. They are phase-wise going for 2 hospitals from each province. So there are 8 hospitals and 1 from the AJK. So 9 hospitals, they have planned the visits, and they will be, because it depends, they want to give the medicine to the hospital which are having trained pediatric oncologists and trained pharmacists who can make the medicines, prepare the medicines. But the problem is many of the hospitals that don't have the pharmacies, so we don't know will they be delivering the medicine to us or not.
Okay, thank you.
Thank you.
So we will take the last question of the session, short question.
Yeah, thank you. Adnan Bhutan from Indiana University. So Mike, I guess it's a comment to Salim about the results from Malawi, which were much better than many other low and middle income countries. What I would tell you is that the main pediatric surgical center in Blantyre, in 2015, they built a dedicated surgical center for post-op care, which included 8-bed ICU as well. So, I think somebody had mentioned, a lot of early mortality happens because of post-operative infections and, post-operative care in general. So I think as you guys all try and collaborate, surgeons, radiation oncologists, radiation therapists, it would be important to have stakeholders from the post-operative care perspectives, Dr. Sadia and others who I think do a fantastic job. So just wanted to give you some perspective of why Malawi's numbers are at least partially. We can't take complete credit for it. I actually helped build the ICU in Malawi, so know a little bit about the history of that place.
Absolutely. This you can't. No man is an island, And none of this happens without multidisciplinary collaboration. Capacity building is not just for one group. It has to go hand in glove, no doubt.
Okay, so here with this, we are ending this session. I would like to thank our speakers, especially Dr. Filippo, who has joined us online. Thank you so much. And all the participants for the active participation. Thank you so much. So the next session would be right at 11 o'clock? 11?
11:20.
11:20.
Of our speakers and participants. And then we will have a tea or coffee break, and then we will come back at 11:20 for the second session.
Thank you.
So nice to meet you. क्या कर रहे हो काम आजकल? बस ट्रेनिंग कंप्लीट हो गई है, एग्जाम दिया था केमिस्ट्री हुआ अनफॉर्चुनेटली। तो बात नहीं, that's part of life. बस उसी में ही कोशिश कर रही हूँ, कोयटा में एडजस्ट हो जाऊंगी आई गेस। कोयटा में प्रीजन कॉलेज की है थी? हाँ जी। ओह, गुड गुड। अच्छा, इंग्लिश का जो है Okay, this week? This week. I think do they want just a session with speakers की सारे जो लोग attend किया जा सकते हैं। फोटो को बताओ। सबकी तो फोटोग्राफी सारी अच्छी आती है। कभी सभी सेशन वालों की ले लो ना। सिर्फ जो चेयर और स्पीकर You start. Start नहीं किया। आजे आजे सर। तो हम मतलब है नहीं कैसे हम बोल दिया। मैं भी कर विंडोज पे ट्राई कर रहे विंडोज वाले से बुलाया ये इसने हमारे को आ जाता था last year being isolated for like 6 months again then we have to get कल वर्षा को चेक आउट कर हाँ चले यार बोलते था कि एक तस्वीर आ जाए साथ ही
आ जाए आ जाए
स्क्रीन वाला है सेल फोन से लेने लगे इन दिनों है ना आ अच्छा Thank you. Thank you.
बड़े वे हैं कि मैं ये वो कर रहा था कि आ रहा है या नहीं वो मे बी दैट they lost. I mean it's okay.
तो किससे पूछते हैं?
लंबी चौड़ी टॉक तो नहीं है कोई yeah so it can be
मसला ये होता है कि as you if it goes up to the hepatic veins तो वो hepatic veins के अंदर भी चला जाता है. So at that point you have to go on bypass. आप bypass के अलावा नहीं कर सकते.
लेकिन वहां तक पहुंचे ना डॉक्टर अली वो कह रहे हैं we always fight with them about this लेकिन हमने नहीं काटना होता ना इसलिए डॉक्टर आसाम Oh, welcome. I'm Dr. Alina, Chair of the Symposium. Thank you for coming here. ये हमारी सर्जिकल टीम है.
अच्छा, अस्सलाम वालेकुम. डॉक्टर अब्दुल वाहिद. मैं पेशावर. ठीक ठाक. You good man?
साजिद अली. साजिद अली, I am pediatric surgeon.
क्या वो है आज अभी?
अभी विम्स ट्यूमर पे था सर. 3 थे विम्स ट्यूमर पे था.
अच्छा हो गया.
जी जी कंप्लीट हो गया. अभी सेकंड स्टार्ट होगा. अभी सेकंड स्टार्ट होगा. नहीं नाउ अभी इंटेंसिव केयर है और दूसरा विम्स का सेशन खत्म हो गया.
ओए मैंने बस
हाँ जी अच्छा सेशन था.
मेरे पास एक पेशेंट है आजकल ये 2-3 महीने पहले.
अच्छा
यानी लड़की है कोई 2 साल की and she had rough dyspnea or bilateral Wilms tumor with secondary lung और उसमें हार्ट में वो भी थ्रोम्बोसिस.
डिफिकल्ट केस.
Please. So we gave her chemotherapy.
अच्छा
कोई 4 कोर्सेज हो गए. काफी अच्छी हो गई है. Just I was thinking कि अगर मजीद वो हो जाए तो मैं go for surgery.
आपके पास है उधर सर्जरी? कौन है सर्जरी कौन करता है?
सर्जरी हमारे पास वो फिजिशियन है.
अच्छा
उसमें RMI में और पीडियाट्रिक सर्जन है.
जी ठीक है.
बाकी भी है मतलब उसमें गवर्नमेंट्स उस पे तो लेट्स होप
नहीं थैंक यू सर नाइस
और
जी जी सर
तो अभी
चले अभी सेशन सर स्टार्ट होगा बस 11 अभी ये ब्रेक है बीच में तो ये गेस्ट वगैरह को हम
ठीक यस
लेकिन जो इसमें लिखा होगा ना कि आगे में इसको देख लेते हैं सिस्टम हमारा अभी नहीं है साहब अभी देखते हैं देखिए स्ट्रैटेजी है नेचुरल सोसाइटी रेफरल सिस्टम एस्टैब्लिश प्रैक्टिकल पॉलिसीज एंड ये रेफरल सिस्टम के टैक्स हमने बाद में Paediatric Oncology Center, Shaukat Fellowship. Triangle workers. Intervention is IV. Yeah. Medical programs and technology. Medical care program. Diagnostic. Diagnostic to
मैं ग्रुप में किसी में डाल दूं ताकि ऑडियंस आ जाए जो चीज रहेगा ना तो पता नहीं टाइम पहले आप वेलकम कर दें और फिर मैं गेस्ट स्पीकर बोल अदनान टी बिटा में क्या है ये उनको बटर था सारे बटर था जो काफी गेस्ट स्पीकर आते रहते हैं ना You should start. Yeah, the bar. Jazakallah.
Assalamu alaikum, everyone. We're going to start our next session, which is about pediatric oncocritical care. And I would like to thank my guest speakers and my co-chair, Dr. Tahmina Kazmi. Dr. Tahmina is the pediatric cardiologist at Children's Hospital, and she does cross-cover Shaukat Khanum Hospital as well. Thank you, Dr. Tahmina. So we're going to start with our first speaker, Dr. Adnan Bhutta.
For inviting us. Our first guest speaker is Dr. Adnan Bhutta.
He is a clinical professor of pediatrics and division chief of pediatric critical care medicine at Indiana University of School of Medicine and Riley's Children's Health. He previously held tenured faculty position at the University of Arkansas for the Medical Sciences and University of Maryland School of Medicine. Dr. Bhutta has over 2 decades of the clinical, academic, and global leadership experience. He has led major international researches, collaborations, such as the Global Parity Study. And today, he will be talking about the etiology and outcomes of critically ill children with hematologic and oncological diagnosis, a secondary analysis of the Global Parity Study. Sir, please.
Thank you very much, Dr. Sadia, Dr. Tehmina. First of all, thank you for inviting me. It's always a pleasure to come back home and spend some time in Lahore. And every time I come back, I see some new buildings go up, some new roads go down. So it's been a nice experience. So I wanted to talk to you in very general terms about sort of epidemiology of critical illness, and then focus a little bit on within the larger cohort of kids who are critically ill, where does the HEMONC population fall, and what are their outcomes? But before I sort of set the stage for what the Global Parity Study was, I just wanted to declare that I have no conflict of interest other than I was the primary investigator of the Global Parity Study. So it's something that is very close and near and dear to my heart. What I want you to come away with at the end of this talk is to understand the epidemiology of critical illness in children in low and middle income countries, know the leading causes of critical illness and mortality in children under 5 years of age in low and middle income countries, and then develop some understanding of the outcomes of critically ill children with hematologic and oncologic diseases. And one of the drivers for my undertaking all of this work that I will talk to you for the next little bit is because I strongly feel that critical care is an essential component of global health. That is something that is now gaining traction both in Pakistan, but worldwide. The people understand the importance of critical care for all the ills that COVID brought upon us. One of the benefits or one of the positives was that people understood that critical care is an essential part of healthcare. And so that was always my motivation, is for people to walk away knowing that when we talk about global health, we cannot take critical care out of that conversation. So everybody probably has seen this graph or something similar to it. The world in the last 35 years or so has seen a dramatic reduction in under 5 childhood mortality. So in 1990, when I was a medical student, the first UNICEF survey had come out and said that the under 5 childhood mortality was almost 100 children die before out of every 1,000 live births die before they reach their 5th birthday. Most of these deaths, as all of you know, happen in the neonatal time period as well as early infancy. But there's certainly progression and loss of life along the whole spectrum of your childhood. In Pakistan, again, the under 5 childhood mortality rate was 140 in 1990. So out of every 1,000 live births, 140 children died before they reached their 5th birthday. Now that level has thankfully been cut by more than half. So it's in the around 50 or 60, and probably steadily coming down because of everything that this group has done and many other groups are doing across the country. But still, the numbers are high. If you compare under 5 childhood mortality in the developed world, that is usually in the single digits. So 9, 10, in the US, it's 12. children die before reaching their 5th birthday. So we still have a long way to go. We have a high bar to achieve. And most of these developments that have happened in reduction in childhood mortality can be directly attributed to the collective effort of all of us, all globally. So physicians, NGOs, governments, United Nations, it's been a huge effort for all the negativity in the world for the last 5 or 10 years. One of the biggest positives I think that we can take away, that humanity collectively, when it wills it, can move mountains. This was a huge reduction in childhood mortality that has happened in our lifetimes. So, and as you know, one of the early drivers for collective action was the Millennium Declaration of the United Nations General Assembly in 2000, in which one of the key components of that, component number 4, was to reduce childhood mortality. Along with some basic essentials that we all know. And the focus correctly was on preventing disease, preventing immunizable diseases, providing antenatal care, so children were born, providing good postnatal care, malaria eradication, access to nutrition, promotion of breastfeeding and nutritional supplementation. For those of us in the room who were around in the 1990s, the UNICEF used to push GOBI FFF, or initially it used to be GOBI, was growth monitoring, oral rehydration, breastfeeding, and immunization. That was sort of the big push from from the United Nations. But since then, a lot, they added more components to it, and it has, and then because of the success that people saw in the first and second decade of this century, there was another United Nations General Assembly which set future goals for further reduction in childhood mortality, but it was part and parcel of multiple other efforts around poverty reduction, improving healthcare, improving environment, improving law and order, improving the financial condition of the world. So they became much more ambitious. But if you look at where we sort of fit in as pediatricians, we fit in the sustainable global sustainable development agenda number 3, which was good health. And within that, the goal by 2030 was to end preventable deaths of newborns and children under 5 years of age, with all countries aiming to reduce neonatal mortality to less than 12 and under 5 mortality to 25. So Pakistan is still almost twice as much as a country, a little bit more than twice as much as what the goal, the stated goal is. Additional targets were to end the epidemic of AIDS, tuberculosis, malaria, and other tropical diseases, and to reduce premature mortality from non-communicable diseases through prevention and treatment, which includes cancers and hematologic diseases, and to have the number of global deaths and injuries from road traffic accidents. So this is a figure I chose from the Global Burden of Disease publication from, I believe it's from 2021 or 2020, in which they sort of lay out what the leading causes of under 5 childhood mortality are. But I want you to sort of focus on maybe the top 3 or 4 lines. And what you see is globally, most of the deaths in neonates happen because of maternal and neonatal disorders. But in kids who are older than 28 days, obviously that number is smaller, and then they have other issues like respiratory infections and enteric infections, diarrhea, that lead to their mortality. However, if you look at the different region or different categories of country categorized by their socio-demographic index. And Pakistan sort of falls in the, I don't know where we are this year, but we used to be in the low middle. The etiology of childhood death shifts. And if you, if you notice, I don't know if I can see it. Nope. Okay. If you notice that the deaths from oncologic diseases, which is a blue bar. Let me see if I don't know if that's visible or not. One second. Okay. Okay. The oncologic diseases, the proportion of deaths that happen from oncologic diseases is actually pretty low in low SDI. But as the country's SDI status improves, the proportion of deaths that happen from oncologic diseases actually starts going up. And it's not because there's more cancer now. It's because the deaths from other more preventable causes is actually going down. So the proportions are changing as the country's income level changes. And this is not just true at a country level, as all of you know. It's also true at the level within the country. There's regional disparities. You know, the pattern of mortality in Lahore or Karachi is very different from Las Bela or Sangar, right? So the same disparities you will see within each country as well. So I think Salim Islam in the last talk showed a map similar to this, which shows that most childhood mortality is still occurring in sub-Saharan Africa, Afghanistan, Pakistan, and the rest of South Asia. The highest rates of childhood mortality still are, and that sort of closely is associated with poverty rates. So just as I was talking about the disparities, this is a study from Dr. Zulfikar Bhutta's group from about 4 years ago. They are working in rural Pakistan and trying to sort of look at mortality patterns. And what they showed very nicely is the figure A is Las Bela and figure B is Sangar, and Las Bela has the highest mortality rate in their study group, and Sangar has the lowest. And one of the factors that they showed very nicely was that Sangar actually happens to have a lot more hospitals, and the mortality around the hospital where the hospitals are is actually quite low. Las Bela has much fewer hospitals, and so their mortality rates are quite high. So the presence of healthcare facility within a distance that families can access actually is a big predictor now of childhood mortality, which takes me to my sort of next point. This is a diagram from a paper from Dr. Keith English in Kenya, who sort of has hypothesized, and which I actually believe in, is that as health systems strengthen, so this is on the x-axis, this is strength of health system and average life expectancy. On the y-axis is your total mortality in a population. So you know what he's trying to show is that as your health systems get stronger, your out of hospital mortality goes down. So most people are able to access hospitals because you now have access to healthcare facilities. But then the mortality inside the hospitals goes up, right? Because they're not dying at home. They're coming to you in the hospital, really, really sick, and then they die in the hospital, right? So but what you need to do is to then improve the quality of care in the hospital to be able to bend the curve this way. And once you start improving the quality of care in each hospital, then you will reap the benefits of higher life expectancy and a strong health system. So that's sort of what has motivated us in studying what kind of hospital mortality patterns exist globally. So we initially did a systematic review in which we looked at the published literature to estimate the cause-specific hospital admissions and mortality in low and middle income countries. This was over a period of 2005 to 2021. And we screened more than almost 30,000 studies and ended up with about 250 studies that had data on more than 21 million patients. And this is the map of the countries that were included. So mostly South America, Africa, and Asia. And what we found, as probably all of you know, is the most common causes of hospital admissions were respiratory, followed by infectious diseases, followed by gastrointestinal. But the most common cause of mortality were infectious disease causes, so sepsis, malaria, etc., followed by respiratory, so pneumonia, bronchiolitis. But all-cause mortality in the hospital was about 4.1%. Case fatality rates, again, were highest for kids who were presenting with neurologic issues, followed by cardiovascular and congenital. So, and then there was a big regional variation in hospital mortality that was highest in South Asia, followed by Sub-Saharan Africa, and was lowest in North America. That sort of prompted us to do a large multi-center prospective study to truly understand the epidemiology of critical illness, because we were interested to measure the prevalence of outcomes associated with pediatric critical illness in resource-limited settings. We wanted to determine the etiology and prevalence of critical illness, measure hospital outcomes, and determine hospital resource utilization in these children. So our primary outcome was to just understand how many of 100 kids who present to a hospital, how many are critically ill, right? And we defined critical illness as death within the first 48 hours, need for a higher level of care or requiring intensive care level intervention, so vasoactive support, non-invasive or invasive mechanical ventilation, regardless of the location of where that care is delivered. So it could be delivered in the ER, in a high dependency unit, or an ICU. And then the secondary outcomes were to look at etiology of critical illness, mortality, and cause of death, and resource utilization. So we ended up with 46 sites in 19 countries. Mashallah, we had 3 sites from Pakistan, 2 in Karachi Civil Hospital and Aga Khan, and 1 in Larkana, the Mohtarma Benazir Bhutto Shaheed Medical School. And this is sort of the spread of our centers. We ended up with about more than 7,000 patients enrolled. Most of them presented to the emergency room, about 6,364, but there were about 1,093 direct admissions also, which most oncology patients would probably, in most places, show up in this category. And then out of these 7,000 patients, about 2,600 were admitted. And about out of that, 2,300 were discharged. There were 49 deaths. And then there was a significant number that were lost to follow-up. So the headline results for global parity was that of all the patients who present to an emergency room or were directly admitted, almost 35% get admitted, and the all-cause mortality was 0.9%. But the prevalence of critical illness in those children was 13%. So out of 100 patients who present to the hospital, 13 are critically ill at the time of their presentation. And the mortality in the critically ill cohort was 6.3%. About 60% of all deaths happen within the first 48 hours of presentation. That sort of underscores the need for good emergency rooms, good ICUs where you can stabilize these patients, make sure they survive that initial period of instability so that they can get their more definitive care. So the highest prevalence of critical illness was obviously in the lowest least developed countries, right? So it was 28% in sub-Saharan, it was 28% overall in sub-Saharan Africa, was 30%. Infants, obviously from age from 1 to 11 months, had the highest proportion of critical illness. And if they had comorbidities such as sickle cell or more than 2 comorbidities, the risk of presenting with as critically ill also increased significantly. And the top diagnoses that patients present with are pneumonia, sepsis, and septic shock, and malaria. So amongst the patients who were admitted to the hospital, the in-hospital mortality was 1.8%. 59% of the deaths happened within the first 48 hours, as I mentioned before. And the length of stays were different. Obviously, critically ill patients stayed longer. Non-critically ill patients were able to go home sooner. This is the highlighted area in red, just shows you the 3 sites within Pakistan. And actually, the mortality in Pakistan was really good. So the first site is in Larkana, and the other 2 sites are the 2 sites in Karachi, and the mortality rates there are around 1%. So I think our emergency rooms are doing a good job of stabilizing these patients. So moving on to the hem-onc population. So overall, and I'll sort of give you the distribution of what I mean by the hem-onc population. So, because that's a big catch-all term. But as an intensivist, all hem-oncers are the same. No, I'm just kidding. So out of the 7,500 or so patients that we had enrolled in our study, about 361 were patients that we classified as patients with hematological or oncologic diseases. That's primary. So about 4.79% of these of our overall cohort. But out of the patients who were deemed critically ill, the 985 patients who were deemed critically ill, 134 of them were patients with underlying hematological or oncologic disease. So that ratio then jumped to 13.6%. So patients with hematological or oncologic disease, obviously we all know that, have a disproportionate share compared to their overall prevalence in presenting to hospitals and with critical illness. So we're still analyzing this data, and that's why I have the no photography sign up there. But the primary diagnosis of a malignancy was carried by 131 patients, 45 of the ones with who were critically ill. Sickle cell, because in Africa that's a big issue, had a really high number as well, followed by thalassemia and patients presenting with fever and neutropenia, who were also patients with cancer. So surprisingly, there were no deaths in patients who had an underlying oncologic diagnosis in our cohort. The only deaths that happened were in patients who had the underlying sickle cell disease, which is very interesting, which is very gratifying. It's good to know that we can stabilize hem-onc patients, at least in our sample. There were no deaths. Interestingly, patients who present with sickle cell disease, only 7.5% of them present to places that have an ICU. But for patients who are presenting with oncologic diseases, almost 100% of them are presenting in places that have a pediatric ICU or are ICU capable. So I think that makes a huge difference in outcomes. So at least that's my biased opinion. Separately, we're looking at another cohort of patients who present primarily with respiratory illnesses or hypoxia. And what we show is that for patients who present to places that have no ability to provide oxygen or any kind of respiratory support, mortality is about 12%. But in places that have ability to provide ventilators, the mortality falls to 1%. Places that have advanced therapies like high frequency or ECMO, the mortality actually bumps up a little bit, as we all know. So This is the same concept. So what I really wanted to sort of point out was that all oncologic care, at least in our sample, was provided in centers that had ICU capabilities. So what are the implications of our study? That we need to invest when we invest in oncologic care or cardiac care or neurologic care, we also need to concurrently build in emergency and pediatric critical care services, because to provide better oncologic care or any other types of subtypes of care, you have to have the basic infrastructure of good emergency and pediatric critical care services. And we also certainly need to focus on building strengthening our first level primary and district taluka hospitals and referral systems, considering linking them with things like telemedicine so you can easily access those patients from the outside. So to me, again, this is what I think of when somebody talks about the ICU or critical care. But now I also think of these patients who are laying there with bubble CPAP as also critically ill, and they're also undergoing critical care therapy. So the geography doesn't matter. It doesn't matter if you have an ICU or not. What you are able to provide is what critical care is. Thankfully, there is now a global mandate for strengthening emergency critical and operative care that just got passed by the WHO General Assembly last year, which asks each member country to develop its action plan on how they will strengthen the basic infrastructure of emergency critical care and post-operative care. So I think, as we think about, how care is provided in subpopulations of patients, you have to also invest in, because these are basic things that all patients need. So not just oncologic patients, all patients need them. And unless we start investing in better emergency and critical care, we will not be able to bring down the under 5 mortality rate from 50 to the stated goal of 25. You can only do so much with prevention. At some point, you have to provide better treatment. And most of the mortalities that happen early at the time of admission. So early recognition, early treatment is key. So with that, I will end. Thank you very much for your time, and we'll be happy to answer any questions later.
Thank you very much, Dr. Tariq. We will take the questions at the end. Now, the next guest speaker, Dr. Ikramul Haq. Dr. Haq is the Division Chief of Pediatric Critical Care at Sidra Medicine, Doha, Qatar. He is leading the division in building a pediatric critical care program of excellence. He graduated from the Doha Medical College, Pakistan, following which he completed his residency and fellowship and training in the USA. He is American board certified in general pediatrics and pediatric critical care medicine and previously served at the University of Texas Health in Houston, USA. Today, he is talking about the critically ill hematopoietic stem cell transplantation patients in the pediatric intensive care units. He will talk about the risk, rescue, and recovery. Sir, please.
Assalamu alaikum, everyone. Good morning. It's nice to be back again in Lahore. Every time I come here, it's just like really fun. 2 days, shortest stay, but I'm grateful for the organizing committee and scientific committee for inviting me to this talk. So today, I'm going to try to kind of use a little bit of intensivist lens, right? And I've tried to incorporate all the audience which are here, sitting here, into this thing. So, we're going to talk about the hematopoietic stem cell transplant and the critical illness related with this therapy, and what can we do about the risk, rescue, and recovery in these patients. No conflict of interest I have related to this presentation. I'm going to walk you guys through the what is I call the intensivist view of what hematopoietic stem cell transplant is, and just know what are the major things which we come across when we are dealing with this patient from an intensivist standpoint. And then we look at some of the literature which address the key complications, prognostic factors related to it, And I'll try to summarize whatever we have with the disclaimer that we don't have a lot of data to back up the stuff which we say we can do about these patients. One more disclaimer I have, and I just don't know who to complain about it, which is rheumatologist or our oncologist. You know, these medications, they are coming up with new medicines. They have very difficult names. And so I'm still learning at New English how to pronounce them, very well to say. And so, you know, maybe a medication with a first name and last name rather than putting everything together. So if I have pronunciation problems, please correct me, but just, you know that I am kind of challenged in that way. So for majority of the, you know, the stem cell transplant patients, you guys know the journey is not straight, right? You guys will resonate with that. The journey, although we seem like a straight path, you get the transplant and you're out straightforward. The journey is very convoluted, right? And it can turn critical a lot of times. So just kind of summary of this is how I look at it, and it may be very simplistic model. So no offense to oncology group, they probably have much more information. But the way I look at it is that there are three distinct phases of stem cell transplant. One which we are not really very involved with, but I've just put over here on the left side, as you can see, basically you collect stem cells, right? Could be different sources. You can have bone marrow, you can have peripheral stem cells, or you can have cord blood. Then there is something oncologists people do, they condition these cells, right? So before you get those bloods, there's some sort of protocol they do. I have no idea what they do, but then cells are prepared to be given. And during that time also, they are conditioning their patients also. So what's called patient conditioning. And the way I understand is that you wipe off the bone marrow of the patient itself so that doesn't interfere with. Basic idea is to remove their immunity that is coming from the marrow, and then you introduce a new cell system which can create a new immunity in the patient, right? And so with that, we have these three phases, and you guys probably are very well versed with the first phase, which is called the pre-engraftment. So your patient has bone marrow, which is basically wiped off, and then you infuse these cells, right? And that's called pre-engraftment. I have learned from oncology group that the engraftment means that you have, the way we look at it, do you have neutrophils coming or not? So basically, platelet count recovery and neutrophil recovery is what we kind of understand how you gauge if a engraftment, which is a very scientific and, you know, like a big term, people go, patient is engraft or not. I don't know, but basically we say, do they have white blood cells coming back up or not? So there's this time frame. So you can imagine there are no what we call neutropenic patients, right? And so they are profoundly immunocompromised at this time. So they don't look bad. You get the transplant done, and then you don't look bad, but they're profoundly immunocompromised. So from our angle, what can happen to them? Of course, sepsis jumps up, right? And we look at infections. So we look for those if they get ill, mucositis, you can have neutropenic sepsis. And also allowing this time frame when the bone marrow is trying to adapt to the infusions you're giving them, they can have this cytokine release type phenomena in some transplant patients, but also is known in CAR T therapies, right? This is followed by a post-engraftment early phase, which is now the bone marrow is building up the immune system. And they have, thank you so much. I guess you guys felt it. Sorry, I think I have caught something during the flight. Influenza is right now going up. And in this time of within the 100 days of the transplant, you see these problems, right? And these are important for us to know as a whole group. Infections, we have something called graft versus host disease, you know, sinusoidal obstruction syndrome or veno-occlusive disease. You have diffuse alveolar hemorrhage as a problem. You have press or encephalopathy, which is seen in some patients, and a microangiopathy, thrombotic, which is transplant associated. And then you have beyond 100 days time frame, which is the late phase post-engraftment year. You have the immunity thing in this times. The immunity is learning the body from what you are and what is foreign and what is yours, right? So some data of what happens, I was looking for it, so I apologize if some of you guys have these papers published, but all I can find is these two papers will relate to that. This is Lahore Children's Hospital's data, I think 5 years of transplant data. What you see over here, what is very important is that there is significant percentage of these patients which will get into trouble. So if you work in general floor, ICU, something, you are going to see these patients which have a problem. As you can see, acute graft versus host disease infections remains to be a big time problem for these patients. There is another study published from, I believe, Army group here, which also have the primary immune system problem patients where they did the transplants. HLH in about half of the patients, and then a significant percentage of patients with SCID. And the survival rate is pretty good, especially for fully matched HLA transplants. But again, if you look at this, a significant population of these patients will have problems. So we better learn this and go from it. What the data suggests overall, just as a summary, is that you will have about a third of patients will come to the ICU at some point after the transplants. So they will get sick. A majority of things will be respiratory and sepsis that we need to deal with, and that can appear at any time during these phases. But you have these specific things, and I've tried to list over here what the sort of the common presentation timeframes and incidence of these things are. Of course, these are based on the data from different places, different practices. So it could be, but these all can appear, and I'll try to touch base with them. This study is published from Columbia recently this year, which actually looked at what happens to these patients who get admitted to the ICU. So you can see in this study that about half of the patients who get to the ICU after transplant will require respiratory support for respiratory failure. About 40% of them will have cardiovascular instability. So significant, like half of those patients will require some intervention. And when they looked at what did you do, so basically they provided mechanical ventilation for about 72% of those patients, and a inotropic and vasopressor infusion, about 80% of them. So pretty, you know, in the ICU settings, we'll call they are pretty sick patients, right, from that angle. And if you look at the non-survivors who did not make it, basically they were on invasive mechanical ventilation. They had higher vasoactive inotropic scores. Basically, we mean they required a lot of medications for their hemodynamic stability, and they were on renal replacement therapy and developed multi-organ failure. So this is not a you know, a surprise, but that is what we see. Another study from Saudi, this is also a recent study. They published their results of stem cells in 173 patients. Their mortality reported is 41%, the patients who got critically ill. And if you look at the multivariate analysis they did for the risk, you can see what jumps out is, again, the same thing, which is a need for mechanical ventilation and inotropic score, which is a very high odds ratio of death. What happens to these patients except mortality, right? So that's not the only thing. They stay in the ICU for a long time. So somewhere about a median of 8 to 15 days in the ICU stay has been reported as, you know, their time in the ICU. And you can see once you get there and you have that much time in the ICU, the mortality is extremely high. So to make connection, this is sort of what an intensivist will see, right? So we had this case years ago, a 9-year-old AML, post-hematopoietic stem cell transplant patient, 12 days out. He presented to the clinic with fever, tachypnea, and abdominal pain, and was then admitted to the floor for observation, and they started broad-spectrum antibiotics on this patient, right? Infection is considered to be, this is the pre-engraftment time frame. So what happened on the floor, he had rapid deterioration. In about 12 hours, he developed severe hypoxemia and became hypotensive, right? They had by that time some labs came in. The bilirubin was 4.2 milligrams per deciliter, and the chest X-ray and ultrasounds are shown below. So if you can see on the chest X-ray, this looks like bilateral infiltrates. Everybody agrees with me, this could potentially, with hypoxia, fit the definition of ARDS, right? And then the right side, you see a liver ultrasound. This is portal vein, and it's looking from the blood flow in the portal vein. So on depending upon how you're holding the probe, the blue color you see on the portal vein. Mark it. Anyway, so you see over here, the red is going towards the liver. Portal vein flow is usually towards the liver, but what you see over here is this blue flow, which means it's going away from the liver. And that's one of the signs of sinusoidal obstruction, right? So basically, we admitted this patient with ARDS and SOS together. So what happened that there is a rapid response system, of course, in our hospital, so they called rapidly, we transferred the patient immediately, end up getting intubated on mechanical ventilation. Initially, we started some vasopressors for blood pressure support, and then once the blood pressure was stabilized, we started diuretics. And then this medication, defibrotide, was immediately started, plus we added some antifungals. Overall, although you look at the data, these patients will probably have a very high mortality, but we were successful in this case. And so a patient was extubated in 9 days and then discharged on the 12th day from the ICU back to floor on oxygen. So this is kind of the snap you will see. What it tells you also is that it is a teamwork. And we have to come through together. Just engraftment after the transplant is not the success. You have to get the patient through the complications, right? And that's what the message is. So pediatricians, my friends over here, your job is to recognize early and timely referral. We have to figure out a way of talking to each other in better ways. Oncologists can enlighten us. Okay, this is the problems you guys are going to be coming across. So once they come in, anticipate what problems we'll have and monitoring advices. And of course, where we come in is that we just add a timely fashion intervention for these patients to do. So I will just go through some of these complications with you guys and whatever data I could find. There is a recent consensus paper that was published recently, a few months ago, that talks about a lot of this, and I will recommend that for you guys to do. What we don't know so far from intensivist perspective is a lot of questions. Basically, it tells us we don't know much. We don't know, the fluid management strategy. Time delays are critical in these patients, as you know. We don't know that what type of patients will be okay with non-invasive ventilation. And then more so is that what time, when time comes, when to intubate these patients. How do you balance the immunosuppression with infection control? And then we need to have better markers, which we don't at this point, which can tell us how the patient is doing, right? So all sorts of problems are there, we know, but one thing which is becoming very common is coming up with the clinical pathway, which means you come up with your own system of recognizing the patients who are getting sick. How do you pick them up from the normal thing? As you know, in hematopoietic stem cell transplant patients, vital signs abnormality is actually common. That could be a common thing on the floor. Tachycardia is sometimes, it would be there already before you can know if it is a problem. You need to do early labs and imaging to figure out scenarios and then initiate rapid response, rapid treatments. ICU consult early if you can, and then start for those things which we know what the specific therapies are, we can start that early. And one thing which is surfacing is that you need to really collaborate with your oncology team, right? So what we do in our ICU is that we have daily rounds with them. They come and then we do rounds together, the whole group. And we feel like that's much beneficial for that. And this is just like few recommendations. When can you call ICU? Please, I would just say don't wait for a full-blown septic shock before you involve ICU. We're better off knowing it before. or severe ARDS. So these are some suggestions people are saying. You start seeing this, start calling it, and don't be worried about the yelling and screaming of the ICU attending physician. That can sometimes happen. Just ignore them. They are under stress. This complication, pulmonary hemorrhage, right? These are the lung complications. So basically, you guys know these patients will present, they will have cough, hemoptysis, and all of a sudden will develop oxygen requirement and this stuff. The treatment is essentially, majority is the same thing here. Some of them will require intubation and mechanical ventilation. They do tend to resolve. You correct that coagulopathy and use tranexamic acid for antifibrinolytic response. Pulse steroid seems to do the trick for them. So, you do whatever your protocol is, and then evaluate these patients for TMA or IPS syndromes because they do seem to overlap. And some of those will become diagnostic dilemma for you when that happens. The bleeding is happening because of this. A lot of the time, we shy away from bronchoscopy, although at some point, the oncologist will convince us to go in. Even if you are on high oxygen and you're dying, you will say, get this dose of lorazepam yourself, go ahead and do it, and we'll just go for bronchoscopy to get some samples. But that is really helpful. CT scan, early CT scan in these patients seems to be, a pretty good thing and can help you with that. And we have had 1 or 2 patients, which I can recall, put on ECMO to support them as long as we know there was reversibility of the cause in these patients. The other problem you will see is graft versus host disease, and that is with the mucositis, immune-related phenomena. The thing which is, which is coming up is steroids where we use. There is something called JAK2 inhibitors now they're using. This is one of the medication. Again, I will have a problem, ruxolitinib. This medication is turning out to have a lot of impact, and I'm sure you guys are getting to use it. A lot of that is the standard care which you build in. There is on the right side, I've just an example from Radiation Oncology Group, a journal which published this staging. And so you look at that staging and it tells you how severe it is and how fast you want to go on therapies on this one. This is like one of those kids I mentioned. You can see they will have a weight gain, which is unexplainable. Usually it starts with that. Then you develop abdominal pain and your bilirubin starts going up. You develop ascites. And then some of these patients will have acute kidney injury with that. This is veno-occlusive disease. As I showed you the ultrasound before, very helpful study in that shape. And the medication here is this defibrotide. Usually when we start it, we go for at least 3 weeks of therapy or until we have a resolution of the disease process. Fluid balance is very important in these patients, so we use diuretics. And one of the things which we've been noticing that we are making now an earlier decision to go on renal replacement therapy than testing out the diuretics to see if we can get the fluid off. So if you have the capability, we feel like that's much better. So we just immediately, the patients come and the creatinine medium was even if there was good urine output, we go and put in the VASCAT or dialysis catheter in there to be ready at any given time, and we can start that. Of course, you will do, and these patients, when they do develop multi-organ failure, have very high mortality. So very quick, fast response is needed in these patients to go for. Some patients will have neurological complications, encephalopathy, mostly related to calcineurin inhibitors. But you can have PRES, which has been reported in these patients, and metabolic causes also. The therapies with these patients are usually supportive. The problem which you come across is that what we say is that manage this patient, get the blood pressure under control before you get into a ICP problem, because that what's get troubled. But when they do, I think ICP management would be helpful. The only issue is the patients have low platelets count or have some coagulopathy. The risk is very high of those monitoring things. Transplant-associated thrombotic microangiopathy, and this is sort of like, the multi-system disease is endothelial system that gets affected, and so it affects a lot of mostly kidneys, but you can have it in other organs. In these cases also, you do control the blood pressures, remove the nephrotoxins, DC calcineurin inhibitors if you are on. And then basically this eculizumab is the medication which we have been now started using earlier and earlier. We're seeing some response. Of course, the CRRT, and like I said, this is a therapy which we are jumping ahead now before that. Cytokine release syndrome is not very common. It's most common with CAR-Ts. You guys may have seen those, but if you have haploidentical transplant done in those patients, you can see this. And when this happens, the medication which comes to us is tocilizumab. And that is the first line now for more than grade 2. This looks like a sepsis type picture. So just kind of, you have to watch out for it and monitor your ferritins and CRPs and coagulation studies. And the important thing is to avoid fluid overload. We know in all of these complications, the fluid overload is more than 10%, then you are in trouble. So now I'll just cover some of the things that what I think are helping. You guys know all these therapies which are done in these patients and how do we support them. But some of the things which I would like to point out, what the recent literature is suggesting is early warning scoring system and its implication in these patients, right? This is studies from India. This was the multi-center study from Latin America. And this kind of points out that if you implement pediatric early warning scores, that in overall cancer kids, it will help, and it's associated with reduced clinical deterioration and even mortality in these patients. You know, it's interesting because the next to the ICU, the most sickest patients are on our oncology floor. The nursing staff there and the doctors there are much more comfortable than when any other floors you will go to because they are used to abnormal vital signs. And so the warning scores may not be perfect, but even if it's not very perfect for your patient population, if you implement it, it will help and design a system across it. So that is something which is going forward. Collaboration and a teamwork definitely works. And this is the Indian study which reported their case. And it seems to be a suggestion that if they work with this, having a team which will come do multidisciplinary rounds, share pathways, and make decisions together, they can actually show some improvement in overall survival of these patients. So that is something which you can do. There are lots of other things which are coming down the path. You know, from ICU perspective, we just know the names and things. So of course, some biomarkers, you know, the SD 163 or CD25, they are for more like HLH macrophage activation. So you can monitor them, they can help. The ST2 marker with the GVHD is a promising marker, mostly because if it's high, then we know that the patients will not respond much to our medications. And so, you know, the mortality is high, so that can guide us. And in fact, in adults, I believe that they do it before the transplant to check. And if these numbers are higher before, it kind of guides them is that the problem is going to be problematic. These medications I've mentioned over here. And then, you know, some centers also are looking at now is the use of oxygen versus non-invasive versus, you know, CPAP versus BiPAP, what type of support you do and not all the patients. Important thing is to realize when these things are not working. And that's what we don't fully understand completely, but we have some ideas now. People will tell you that maybe 4 hours or so of application, if it doesn't work, move on to the next level and intubate. CRRT, I already mentioned in renal support that's early is better in these patients. And one message is avoid fluid overload of more than 10% at all cost. That's kind of my pet peeve now with my fellows and everybody. I ask them every day, how much is the fluid overload? And they have to tell me it's not more than 10% yet. Otherwise, we'll be in trouble. With that, I will just stop over here. I hope this was somewhat helpful. And thank you so much for listening.
Thank you, Ram. That's a very informative talk. So we're going to move on to the next talk. Next speaker will be Dr. Adolfo Cardenas Aguirre. Dr. Cardenas is a pediatric intensivist, originally from Mexico, where he led the development of a successful oncology PICU program at Hospital Infantile Telethon de Oncologia, some Spanish there. He's currently a program manager in the Global Critical Care Program of the Global Pediatric Medicine Department at St. Jude Children's Hospital Research Center. He oversees the Global PEWS Implementation Project, EVAT, and PASHA, currently enrolling over 120 centers across the world. He's going to give us a virtual talk on early detection of clinical deterioration in children with cancer.
Hello everyone. Good afternoon. Good morning over there. Thank you very much for the organizers for this kind invitation for this presentation. It is a pleasure for me to be able to talk to you a little bit about the work we're doing about early detection of deterioration in children with cancer. I wonder if, for technical purposes, will you help me move the slides and if you can hear me correctly?
Yes, Adolfo, I can hear you. Yeah,
Perfect. Thank you so much.
thank you for joining.
So, I can't quite see the slides, which I think you will be projecting.
I think you have to screen share, Adolfo.
Okay, yes. Give me a second because I'm having some technical difficulties here.
Can you see the slides now?
Yes, I can see them. Actually, if you could help me move them along, I think that would work best right now because I'm having some problem with my computer. If we can go to the next slide, that would be amazing. Thank you. Can we move to the next slide, please? I'm sorry, could you help me move to the next slides? Okay, think I managed to make it work. Can you please let me know if you can see my slides in a second? Can you see my slides now?
Yes, Adolfo, we can see your slides.
Okay, perfect. Sorry about this technical difficulties. As I was saying, our work is funded by the American Lebanese Syrian Associated Charities, and I have no relevant disclosures related to this talk. So, over the next few minutes, I'd like to share with all of you some details about clinical deterioration in children with cancer and focus a lot on what pediatric early warning systems are and what their impact is in children with cancer, as well as talk about PU's implementation strategies. So, my colleagues before me have already talked about the frequency of critical illness in children and also in children with cancer. We know this is a very frequent problem. 1 out of every 3 or 4 patients with cancer will need critical care at some point during their oncological treatment, regardless of whether they receive it in a PICU or in a hospital ward. And in the USA, this amounts more or less to about 7% of all PQ admissions, but this is increasing across time. And there are, of course, several different factors that are related to this. Some of them have to do with specificity of the etiology of critical illnesses. We've talked or in the previous sessions a little bit about disease-directed therapy, but also the underlying malignancy and infectious complications that can cause these diseases. There's also a biologic component to this with immune dysregulation, endothelial injury, and pre-existing organ injury in children with cancer, as well as disease-specific risk factors and organ-specific risk factors. And what this all adds up to is of higher frequency of critical illnesses and higher mortality for the child that has cancer or has received a stem cell transplant. And of course, delayed identification is a big problem because it leads to increased organ dysfunction, longer ICU length of stay, and higher mortality. It has been described that every hour delay in ICU transfer can increase mortality by around 3%. And the reasons for these delays have to do with failure of our staff to recognize physiological changes and breakdowns in communication. Ideally, we would like all of our patients to follow the green arrow, right? If you have a hospitalized patient and you have their clinical status on the y-axis, they're sick, that's why you have them hospitalized. And you would like them to improve until they can be discharged at the end of the x-axis. But oftentimes our patients, especially children with cancer, follow the red arrow and start deteriorating. At first, this is very subtle. Changes in behavior can be very, very subtle and sometimes are only identified by parents. But as this progresses, there's changes in vital signs and then outright signs of circulatory or respiratory dysfunctions, which can lead to cardiopulmonary arrest. Right? Now, as you can see, there is a gap between the red and the green arrow, and as that gap widens, the effort needed to recover a patient and the chance of that patient recovering, the effort increases and the chance is diminished, right? So what we want is not to identify patients when they are resting or close to it, but rather do it sooner. And for that, early warning scores have been studied for a long time. We need to turn these, though, into systems that facilitate both early identification and early intervention, which is the way we can work on to improve outcomes. If we combine this with the fact that there is a huge disparity in the survival for children with cancer in the world, where some regions of the world can see survivals of childhood cancer treatment up to or above 80%, and some regions of the world have survivals as low as 20%, we see that it is very important to work on these inequities. Deterioration, as we were talking, is a very common issue, particularly in children with cancer. And in this multi-center study done in Latin America, where we evaluated clinical and organizational risk factors for mortality, our group evaluated hospitalized patients in 16 centers. What we found out of over 100,000 patient days and over 10,000 hospital admissions was around 553 clinical deterioration events. Importantly, almost 30% of these died during the event, so quite a high mortality and compatible with some recent meta-analysis about survival or mortality in critical illnesses by the European POCA group. But also very interesting is what happened when we evaluated the different centers on their own. And you can see here 3 different metrics for mortality. 2 for mortality, 1 for frequency of deterioration on the left. And each dot represents one of the 16 hospitals involved in the study. And as you can see, there is a very wide range of the outcomes within these hospitals. Going for a percent of event mortality, which is perhaps one of the simpler metrics here to understand. You can see some centers had mortalities as low as 11%, which are comparable with some high income settings, but while some of them had mortalities as high as 80%. And this led us to think that there are things we do and characteristics at our hospitals that definitely influence patient results. Centers with lower pediatric cancer hospital or pediatric hemato-oncology patient volume and less experience tend to have higher mortality, as do centers that use frequently ICU-level interventions like vasopressors or mechanical ventilation on the ward. Also, centers that have high severity of illness, in our study measured by the PIM2 score and organ dysfunction, when the patient was transferred to PICU, which is we believe a marker of late transfer, also have higher mortality. So this is why deterioration is important and the magnitude of the problem. What can we do about it? There has been a lot of literature about the use of pediatric early warning scores or pediatric early warning systems. And when you want to implement a system like this, what you're looking is actually 2 different things. We want them to be adequately discriminatory of deterioration, right? So this should be able to predict deterioration, death, and or critical illness. And in this sense, it's similar to a diagnostic test. But we also want PUs to have an improvement in outcomes. And for that, measures like quality improvement or quality assurance, that is monitoring our use of PUs, are very important, as are debriefing, feedback, and staff training, as well as the context where we're implementing PUs and the available resources and the interventions that the patients receive. So ideally, if we were to set up a pediatric early warning system, we would want it to perform all the activities you can see on screen. It should be able to detect, but also trigger an alarm, trigger a response from a team of providers that would give specific interventions or treatment to our patients, and then have a debriefing mechanism that can allow us to monitor whether our performance was good or needs to be improved. When a pediatric early warning system then has all of this, there's evidence in general pediatrics, especially, that this leads to shorter time between deterioration and medical interventions, lower severity of illness, shorter ICU stay, and improved interdisciplinary communication and lower hospital mortality. But of course, if we think of this just as a pediatric early warning score, the score will only help us with detection, right? So it's important that this actually becomes a system that triggers a response. And so one example of the way PUs can work is using it in hospitalized children with every set of vital signs. Vital signs is a very common activity that is performed in all centers for hospitalized patients. And so if we can integrate the measurement of PUs with the regular measurement of vital signs, This will allow the nurse performing PUS to actually identify patients that are at low risk for deterioration, which can be flagged as green, or patients that have either a moderate or high risk of deterioration, which can then be flagged for a special medical evaluation. This is, of course, a simplified version of the way PUS works, but it's, I think, an illustrative one. And of course, there are many different types of PUs published out there, but I will start talking about the PUs score, which we are using in our global critical care program and which we are facilitating implementation of with our centers. You will see the name EVAT in many of our slides. EVAT is a Spanish translation of PUS, which stands for Escala de Valoración de Alerta Temprana. A lot of our work started in Latin America, which is why you'll see our Spanish acronym throughout these slides. And our work began some years ago in Guatemala, a middle-income setting in Latin America, in a specific pediatric cancer hospital, which is UNOP. You can see a photo here on my slide. And our validation studies in this setting showed that our PUS is valid to predict the need of implant ICU transfer. The ROC, or the area under receiver operating curve, was close to 1, 0.94. But also our EVAT or PUS score at ICU admission predicted organ dysfunction, severity of illness, the need for critical interventions, and mortality. PUS scores were elevated as much as 24 hours before ICU admission, differentiating cases versus controls. And you can see how the confidence intervals did not cross between these two groups. So very high capacity to identify. And this is, of course, what we frequently see in our day-to-day work, right? We are rounding on a patient. Today, he or she is slightly tachycardic. We don't really know why. And then the next day, when we come back to the hospital, the patient is in the ICU, intubated and with pressors. As I mentioned, there is a correlation between the PUS score when a patient is admitted to the PICU and their length of stay and their mortality. And I would like to highlight here how there is a big jump in survival or mortality when the score of PUS is 5 versus 6, which will be relevant further on. So our group has done a lot of work on PUS implementation. And of course, ideally, this will lead to PUS use, which will bring about benefits for the patient. There are, and I'm going to talk a little bit about the impact on patient outcomes. But we also discovered, as we've worked by, that there's impact at different levels. The providers are impacted by the implementation of PUS. Teamwork within a hospital is also impacted, and institutions are also positively impacted by PUS. I will try to do a brief summary of the findings of some of these studies for you today. This is again going back to our initial work in Guatemala, where PUS implementation reduced the frequency of deterioration event. You can see on the left side of the slide the blue graph, where deterioration event rates were reduced by about a third. And you can also see that in this particular center, the need for ICU days, the need for hospitalized patients for unplanned transfers was also reduced by about 25% pre and post implementation. Going on to more recent work in this Lancet Oncology paper published a couple of years ago now, we saw that after the implementation of PUS in our first 32 centers, there was a 18% reduction mortality in CDE rates. There was also a reduction in ICU interventions and cardiac arrest at the ward and severity of illness at ICU transfer, without an increase in overall resource utilization. Right? So patients were shifted earlier into the ICU, which led to them receiving their vasoactives, mechanical ventilation, and their interventions at the ICU or PICU, and having them then lower severity of illness, and lower need for ICU interventions at the ward. But perhaps more interestingly is that the Pew's impact, that is, the magnitude of the reduction in mortality, was greater in the centers that had higher baseline mortality. So the bigger the problem the hospital had with deterioration mortality, the more impact Pew's had. And we think this can make Pew's a very important tool for equity in outcomes for our patients. Interestingly, within the Latin America region, our study found that the efficacy was similar across centers with different intensive care resources. So whether having a dedicated PICU or a mixed adult ICU, mixed adult and pediatric PICU, hospitals with different nurse-patient ratios, oncology services size levels, and country income levels. Pew's also has shown multiple qualitative impact. We've performed several qualitative studies in St. Jude and the hospital in Guatemala, and these studies have demonstrated that staff appreciate Pew's as a valuable tool to improve the quality of hospital care. It also amplifies the voices of healthcare providers. It increases confidence, empowerment, communication, and this is particularly significant for nurses. Pew's also has a positive impact in communication between providers and the family and enhances teamwork at institutions. I mentioned also that the institution received some positive impact from Pew's. And so basically there is a very significant cost saving. Dr. Nikhil Bhakta, which some of you may be familiar with, one of our faculty here at St. Jude, estimated in the study that the Pew's implementation cost was around $14,000 US, which was mostly indirect. So this was mostly done with time invested by staff into Pew's implementation, which amounted to $7 per hospital admission. But due to the reduction in ICU care, this resulted in a cost saving of over $300,000 US. And so Pew's not only improves quality of care, but also can reduce hospital costs. Of course, it is very important to be able to implement Pew's to actually have an implementation strategy. So we need to go into this with a plan. And we've done a description, but in most cases, a plan that is semi-structured will be successful. What does this mean? Well, for a center to implement Pew's, they need to go through several important milestones. However, the way each center achieves this milestone will be slightly different based on context. This model that you see on screen is based on the knowledge to action framework, and it talks about the way Pew's is implemented within the implementation strategies that we have available at St. Jude. First, identifying the problem and measuring the magnitude, adapting Pew's to the local context. This is a very important step because Pew's systems cannot be used as they work at St. Jude, for instance, in centers in other countries. They need to be adapted for the local context. Assessment of barriers to Pew's use, as well as determining interventions to address these barriers. Also very important is to monitor the use of Pew's with quality metrics, then evaluating outcomes, sustaining Pew's, and doing all of this work in a cyclical manner. So our team has worked on this collaboration networks that use train-the-trainer models. International Pew's experts train a local team that will lead Pew's implementation on a specific center. This local team will then become an expert on implementation methodology, learning stuff about clinical quality improvement, clinical use of Pew's, and implementation science. Very important, as we've discussed, is the monitorization of implementation quality. So outcome and process measures of Pew's use need to be monitored, and these are standardized with a standardized definition of what successful implementation means. So the teams at each hospital learn about QI, implementation science, and PUS use, but needs to be supported by hospital leadership because the introduction of a PUS system will inevitably lead to changes in our workflows and routines. This needs to be supported by leadership at the hospital. And using these models, we've been able to support PUS implementation in several different countries. As I discussed, our team started our work in the Latin America region, and our first PUS implementation program or strategy, which is called EVAT, I've told you this is the Spanish translation, you can see here in Spanish. It is currently enrolled now 113 centers and is about to add a few more centers. Our second project was English language based and aiming to expand in the Sub-Saharan Africa, Middle Eastern, Southern Asia, and Asia Pacific regions, which is Project Pasha. And this project has now enrolled 24 centers, including one center right there beside you in Lahore, Children's Cancer Center, which is implementing PUS right now and being very successful about it. And finally, one of our latest pilot models right now is a Portuguese-based project that is currently just working on Brazil, but that we're hoping to expand to Portuguese-speaking African countries. Together, we have about 140 hospitals implementing PUS across the world. Of course, there are barriers to PUS implementation. It's not as easy as just bringing the system and integrating it in the hospital. And this qualitative study that was done with interviews of PUS implementation leaders that used the CFIR to identify barriers and enablers had some very interesting results. As I've mentioned, PUS needs to be adapted. And so this transformation from the original to the adapted PUS is impacted by barriers that can be found at the inner setting level, the hospital, the individual setting or staff, and the outer setting in the hospital. However, a process that has standardized milestones involving mentorship, adaptation, engagement, pilot testing, very important, full-scale implementation, and evaluation is generally successful for PUS implementation. There are barriers across all different domains, like lack of resources, like resistance of staff to change. But the implementation teams at the different centers have shown that you can leverage the process here at the bottom to actually convert what is a barrier into a facilitator. And one of the simplest examples, but also more illustrative that I'd like to share is a particular center in our program where the head of nursing was initially very resistant to PUS implementation and so represented a very big barrier. However, once this person was involved in the process, actually became an advocate for PUS and became a facilitator of PUS implementation, which was very important for that particular center's success. I want to talk a little bit before we finish this talk about sustainability. It is one of the most significant challenges we face nowadays because while we can frequently implement new interventions in our hospitals, we have very little idea of how long they are sustained. And of course, if you introduce a new thing but stop using it, you stop gaining their benefits. So we know that less than half of new programs are actually sustained with fidelity. And this is very costly, especially when the implementation effort is big. But most important, it bars our patients from receiving the benefits of these interventions, but also breaks the trust of stakeholders. So as a conclusions for our talk today, I just want to highlight clinical deterioration is a common and serious issue in children with cancer. PUS can improve outcomes by facilitating early detection and intervention. And of course, the prediction capacity and the impact can vary by different systems. But Puce implementation, at least from the system that I showed you, EVAT, is feasible in different contexts in low and middle income settings. Implementation science and quality improvement offer valuable tools that we can use to guide Puce implementation. And with successful implementation, we have positive impact at multiple levels. We'll have positive impact on the providers, on the patients, and at the hospital level. And of course, the way to demonstrate this requires a mixture of qualitative and quantitative data. So thank you very much. And if any of you are interested in learning more about Puce, our Puce projects, especially the English version one, you can scan this QR code so you can share your email address with us, or you can also email us at either our project address or my work email address. And I think with that, I hope I didn't go a lot over time with the technical difficulties.
Thank you very much, Adolfo. The talk nicely fits in with the previous two talks, emphasizing on the scope of the mortality in the country and very sick patients and importance of Puce. So the next talk will be on ICU burnout. And for that, I would like to invite my panelist on the chair over here, Dr. Ikramul Haq, Dr. Adnan Bhutta, Dr. Tahmina, and I would like to invite our clinical psychologist, Nasra Hayat. So I will introduce her. She's a clinical psychologist at Shaukat Khanum Hospital. She has served for more than 10 years. She has double MSc in health psychology from London Metropolitan University. Her expertise has been in a variety of areas of patients with cancer and non-cancer patients. She's expert in family and individual counseling related to depression, anxiety, phobia, panic attacks, stress, anger management, adjustment problems, behavioral issues, attention deficit hyperactivity syndrome, and smoking cessation. So I would like all of the panelists on the stage, and then we can have this interactive session. Thank you. All of us have experienced burnout at some stage as we work in a very challenging specialty, which is related to the hemato-oncology patients and intensive care as well. So burnout is a state of emotional, functional state where you feel stressed out by the work-related issues. So I'm going to leave it for the panelists to give us some insight into how they manage the burnout. So starting with Dr. Ikram, if I can ask you, what are the most common sources of burnout that you have experienced during your successful career in ICU of over many years, and you're working in one of the tertiary centers in Qatar? So give your insights, please, sir.
Thank you so much, Sadia. I must admit, on this one, I feel like I'm not really an expert in that sense. Actually, I'm a patient in that sense, right? So when we are talking about this patient, I'm part of this problem, not like really an expert what to do. Of course, some of you guys who are old like me, maybe Salim, we grew up and were raised in a different sort of thing. And I think Adnan would remember that. Our fellowship times when we remember those, there were no duty hours regulations, right? So as fellows, we working, sometimes I remember going home after 3 days of covering the whole weekend. And so, these things do come across and it gets to you. For me, I think I find in what are particularly difficult in our field as we work through are a couple of things. Like, so there is certainly an emotional strain, right? So We take care of very sick patients. Outcomes are uncertain, and you are in that environment trying to do the best you know with very little evidence you have to back up yourself. And so you do. The outcomes, what's going to happen, puts a toll on you. And that, you're continuously doing it, put a strain on yourself. The sort of a moral distress, also what people would describe it in the literature, right? So you get involved in a lot of these things where you're taking care of a patient who you get involved with the family, taking care of it, and the prognosis is not good, and you take care of them, and one day they just pass away, right? And it's my habit to, sort of reflect on it later on, go back and keep on thinking, could I have done something different, right? At what point the trip happened or not happened? So that also creates a little bit of distress dealing with the family afterwards, also, who were hoping for the best. Even at the last time when we were, let's say, starting chest compressions on the patient, the family was hoping this is, they will survive from that standpoint. And also, of course, some of it is our own fault. We have created work environments which are pretty hard for us to handle, right? So staffing is not adequate. We work long hours and deal with the situations. In some ways, we also have not learned how to group together to deal with this. And you take it upon yourself and just think of what your responsibility was rather than. So some of these factors, I believe, staffing plays a role, could lead to a lot of these things, which can eventually lead to burnout scenario.
Thank you, Ikram. Dr. Bhutta, can I ask you, have you developed any coping strategies personally when you're working in this very intense environment? And what is your insight towards coping with this burnout?
So thank you for the question. I don't know if I have a really effective coping strategy, but I would say, I think that the flip of burnout is resilience. And I think instead of focusing on the burnout piece, we have to figure out how can we be resilient. And as an individual, you can have resilience at, you can sort of work on resilience at multiple levels, as an individual, as a team, and as an organization overall, right? So as an individual, I think the biggest thing, well, I would say a few things. Biggest thing is to have something outside of the ICU that keeps you invigorated, right? Because if your life is completely consumed by the ICU, you will not last very long. So, whether that is family, friends, travel, whether that is, your academic activity, so your research or teaching, if you take pleasure in that, whatever brings you pleasure outside of the ICU, you have to have a plan when you start working in an ICU. You have to figure out, outside of the ICU, what is my life? Because if your sole sort of focus in life is the ICU, you will burn out. So I think my coping strategy is my family. My coping strategy is my academic work. My coping strategy is travel, right? So, but I think talking about the other pieces of resilience, one of the things you also have to have, I think, is, what is known as mindfulness, that when you are stressed, when you are facing a situation where there's adverse sort of interaction with a family, you have to be able to detach yourself, maybe in the moment or maybe after a little while, to say, okay, so why is this family upset with me? What is their underlying reason for acting out, right? Or why is Dr. Sadia, I'm sure you have your boss of a few people in this room, right? Why is Dr. Sadia mad at me today, right? What did I do wrong? So you have to be able to, and then say, okay, so she's probably mad at me because I didn't know that I should have gone up on the beep, right? I'm just giving as an example. So some of it is on me, but then if you had gone up on the beep, you need to be able to communicate. And I think we had talked about communication earlier as well, right? So I think you have to have some mindfulness, some time in the moment where you sort of detach yourself from just the immediate work and say, okay, here's what I'm going to do. And then as a team and as an organization, I think you also have to develop that culture where you are actively working on making the teams resilient. And we can talk about that a little bit more later, but I think those to me would be sort of the initial response to your question.
Thank you, Dr. Gupta. Can I ask Dr. Tahmina? You can give us insight into the burnout during your career as well. And what do you think are the most significant barriers in the coping strategies to deal with burnout in your career?
Thank you very much, Dr. Sadia, for inviting us and for asking this question. Yes, we burn out, and we burn out early because we are very much few. Like covering the cardiology into Shaukat Khanum, we are just two. And we get the calls in the middle of the night that please read the ECG. So we just burn out. Yes, sometimes the trained staff is very important. And the critical care of medicine is the right hand of the cardiologist, because I know the heart is the major thing, because it's not only like it's in the center, but it's like managing everything. You are putting the lines and you're asking me for the vegetation. Neutropenic child having infective endocarditis, do the echo. I know there is no vegetation, but you ask, I burn out. So yes, good staffing is very important. You say, this is a pericardial effusion, you have to drain. I know it's only a 5 centimeter pericardial effusion, do not need to drain. So it can be managed. So a good trained staff from the ICU can reduce our burnout. Because if I ask, just make a 4-chamber deer and show me. So what I do many times, I reduce my burnout by taking care of your staff, the residents from the techs. And also rightly said by the Dr. Bhutta that I always have a plan that these 3 days I will not work at SK. I'm on call for the 3 days or for a week, and the next week I will not take the calls. But I keep myself in touch with the patients who I am looking after in my week. So that's the only thing. The teamwork reduces the burnout, I feel. Thank you.
Thank you, Dr. Tahmina. So we'll move to the experts, Nasra Hayat. Thank you for joining, and it's a pleasure to have you here. So we'll start with what are the signs or symptoms of burnout which we should be aware of, and so we can seek help later on.
Thank you so much, Dr. Satya. Usually, a burnout is misdiagnosed with stress because there's blurred line between. Can you hear?
Yes, yeah.
Because there's blurred line between stress and burnout. So if you look at stress, there's over-engagement, there's hyperactivity, a hyperactive emotion, and sometimes there's a loss of energy. So stress can lead to anxiety. And then if you look at the burnout, there's a different type of feelings. There are different type of emotions, mostly physical, emotional health is exhausted. And it often related to your work. On the other hand, stress is related to your family, your social, and many other factors. So there are 3 steps you can diagnose your burnout. Firstly, there is emotional exhaustion. You feel fatigued, drained, overwhelming lack of energy, and then there's feeling of helplessness. And in the next step, there is feeling of cynical attitude towards your colleagues, towards your work, and there's a lack of empathy, and there's lack of concern. In the most worst form, there's reduce of accomplishment. You doubt your colleagues' ability, and then you feel there's no success in your career. So this burnout in the later stage, third stage, can lead to depression, like low mood, sadness, and even suicidal ideation as well.
Okay. So is there any personal or institutional coping strategies that we can that we should know so we can when we diagnose ourselves with these symptoms, we can do them? Yeah.
Thank you. As the panelist said earlier, like resilience building is very good technique. According to me, you need to have your own personal evaluation in the end of the day. Just give 5 minutes to yourself and just root cause everything, whatever is having burden on you. There's one-to-one assessment, there's personal assessment, look at your emotions, feelings, and thought process, and also observation of your other colleagues in a positive way. And frequent and regular assessment, your peak stress time or a high workload. And there's resilience building is very important. How you can enhance your competencies to deal with stress, how you can contribute with your other colleagues, and how you can cope in different situations, and how much control do you have on yourself. And then most importantly, the cognitive behavior techniques, how you can use in a different stressful or burnout situation, like progressive muscle relaxation, body scanning, deep breathing, and obviously lifestyle changes as well, healthy eating habits, daily walk. And then there's another important technique. Whenever you feel stressed or burnout, you should go just sit for 10 minutes, 15 minutes and write about the feelings. Writing and talk is very important whenever you are feel stressed. And then there should be a group meeting as well whenever you feel stressed with your colleagues, where you can talk positively. And there should be a positive reassurance from your colleagues as well. There should not be a critical attitude. You feel you're exhausted, you're stressed, you're always burnt out. So I think these are the best techniques you can use.
Okay. And how can you promote healthy interaction within the group or within your teamwork?
Yeah. So what I feel in my career, because as a mental health professional, we're missing a lot of things because we're working with each other from the many, many years, from the ages, but we don't say salam even. We don't open doors. Sometimes we are not pleasant. We don't smile often. And we don't ask, how are you? How are you feeling? Are you all right? How's your family doing? These are the basic interaction I think we should promote. What we are promoting, we're promoting robotic interactions. We're not looking at ourselves as a person, as an individual. Promote your values. Look at yourself as a person. Then later on, you are professional.
Are you offering any of these coping strategies like in your clinics or at your work at Shaukat Khanum?
Yes, we have a regular well-being programs for the employees, and we have different type of sports group for the patients. We're working on stress management, burnout. Then we have anger management sessions. We have separate sessions for the doctors, stress and burnout. Then we have specialized clinics for wellness programs for employees where they can come and discuss and talk. And secondly, the most important thing I want to talk, there's a taboo and stigma about mental health. Whenever you talk and whenever you introduce yourself, I'm a psychologist, usually people have a different type of shock feeling. Oh, you're assessing us. Oh, we don't want to talk. And really what I have heard in my career, we are afraid of talking to you. So I really men को कहती हूँ कि हम पागलों को treat नहीं करते. I'm trained in normal, healthy interactions. I'm trained for normal people. So you can come, you can discuss, and there is definitely confidentiality, whatever you discuss.
Okay, thank you very much, Nasra. So I will ask the audience if they want to do any suggestions, or do you have any comments regarding burnout in your specialty, and how do you cope within your team? Yeah, yes, Rachel.
Thank you, everyone. I think this is a very critical part of our care while providing care to our patients, especially when we are doing so much of intensive work and working in an intense environment. And besides all what has already been said, I think while seeing patients and all, we do not, I think we haven't developed that, or we do not practice that much the habit of maybe debriefing after seeing patients and all, giving just 1 or 2 minutes after, maybe after each or after 2 or 3 interactions, so that provides the opportunity to just vent out, or being a sounding board for another colleague as well. That helps. I think that fuels resilience in some way or the other. And there's a literature there on some sort of a shorts rounds that happens, and where maybe that can happen for PICU, or that can happen for oncology, where people can sit together and just one of the colleagues volunteer to discuss something or the case or something that stuck with them, and that's not helping them moving forward while they're providing care for their kids. So I think that's important, and we have to develop that culture, and we cannot unless we realize and recognize the need that that is important for us to while caring for our patients. And I think I'm so grateful, and that's so helpful that we are having this session here, and maybe somewhere we have to start from somewhere. So I think that's excellent. Thank you.
Dr. Resham, sorry, I just want to add, we have a modified version of Schwartz round. So we are running burnout support groups for physicians. So what I want to add here for everybody, there is a mass sledge inventory for burnout. So it's a very simple inventory. There is a scoring key in the end, and there are different step process like burnout, physical exhaustion, and then reduce accomplishment. So anyone can use if they feel they are stressed, and they can do their scoring. If they think there is a mild to moderate, they can reframe their coping strategies. And if there is a high score, they can seek professional help as well. So this is mass sledge inventory.
Okay, thank you. So we're open for questions for our respected speakers. I welcome the audience if they have any questions, please.
Thank you very much for highlighting a very important aspect. And I think burnout is a thing which is not taught to the young students, and we have never learned about how to cope with burnout, right? So I feel that we should be talking more about burnout with our junior doctor. And as somebody mentioned, that it is related with stress, and it is also related with a lot of responsibility. And pediatric hemato-oncologists in critical care, I think in everywhere in the world, they are the most who are like at risk of burnout. So I think regarding the coping mechanisms, when I learned leadership, and I learned it pretty late, I learned some of the very important things, like how to stay alive. It is like finding your confidence, which will be like people apart from your workplace, and then anchoring yourself to something, and even identifying your hunger. Like there is a limit to everything, right? So I think these are the concepts which should be taught to the juniors. And now there are a lot of this problem is even more in the new Gen Z. And I think they will we all actually need to work more on our future generations.
Thank you.
You bring a very important point, and just for the sake of audience over here, can you see a show of hand? How many of you who know what burnout is and maybe know about the skills to kind of gauge you on that will feel comfortable going to their boss or whoever is the supervisor and telling them that I'm having these symptoms and I need help in the current environment you work?
No one looks
Right?
like it.
So, okay, at least one. Yes. So, it's very important. It's like, in the aeroplane, right? When they are teaching you that the mask will drop if the plane is having some sort of a problem, and the oxygen, right? So, and they teach you that you need to put the mask first on yourself, right? Because if you don't have oxygen yourself, you cannot help anybody else, right? So it starts from you, right? And rightly so what people said, and I feel like that's where the problem is. We don't really know what burnout is, right? For years, as we were growing up, we felt like this was the part of the problem. Like, this is what comes with the job, right? My job has, salary, benefits, and then also we have this, right? So it's part of it. And you need to kind of, know that. Also, we have to teach our generation along with this. So first we fix ourselves, And then we have to know that this is not normal. You have a part of it, and we teach our juniors to know that this will come throughout their career, and they have to know what to do.
Yeah, I completely agree. And the other point I would want to make is managing burnout is actually certainly an individual's, partly starts with them, but it has to be managed at the team level and an organizational level, right? And so I think leadership that understands that we all function as a team, right? Unfortunately, in our Pakistani culture, in many other cultures, there's a lot of hierarchy, right? I mean, so you are not supposed to go and talk to your head of department about stuff like this, right? Nobody does that. So I think it's the head of the department's responsibility to understand this and create a culture where there's, what is the term is egalitarian, where sort of everybody is on equal footing, right? Especially the ICU is special, but I think all fields, but ICU especially is where each person's value is the same, right? Whether it's a physician, whether it's a nurse, whether it's a therapist, you have to value each and every person that is in that unit, because we cannot succeed in helping our patients if everybody's not working together. And so the sort of the old concept of hierarchical medicine actually exacerbates burnout, because people at every level, even at the top level, because that person doesn't know why things aren't getting better, because then there's issues below. So we have to sort of change our mindset about how we function as a team and how organizations function, and sort of get rid of this mindset of I'm the CEO, or I'm the president, or I'm the professor, I'm the chairman, and so everybody has to respect me, everybody has to say yes sir, no sir. You have to be willing to enter into sort of deep conversations with people and accept criticism when it's sort of sent your way. But the culture should be criticism not for the sake of criticizing, but for the sake of making things better. You're not criticizing somebody because you want to punish them. You're criticizing something because you want that the next patient does not suffer. And unless we get to that level of culture, which is hard to do, but it's doable, and many places have that culture. That'll be the point where I think everybody will succeed.
Thank you, Dr. Bhutta. So we can take more questions from the previous ICU talks, if anyone has any questions.
I have a question to Dr. Bhutta. Dr. Bhutta, you talked about the global parity. How you collected that data from the Sangar and the other areas? What is a database?
So the Sanger slide I showed you was from a different study that was run by Professor Zulfikar Bhutta from AKU. But that data we collected from Chandka, it used to be Chandka, Mohtarma Benazir Bhutto. We had at AKU and Civil Hospital, we had research assistants at each site collecting data prospectively on 4 different days over a period of 1 year. So this was all prospective data collection done by research assistants. Now, I'll tell you, this was an amazing study to do, because our budget, for most studies, at least that are run out of the United States, a study like this would have taken $4 or $5 million. We did this study with $50,000 because people across the globe recognize the importance of critical care, and intensivists wanted to participate in this study without necessarily getting a payback of any sort. So this was an amazing experience to have been a part of.
Very nice, because we are conducting a project with Ohio Cincinnati Children's Hospital, and the Duke Foundation is funding that project. And the 4 countries, Pakistan, Malawi, Brazil, and are in the project in Uganda. And we are collecting the data from all of the sites on a RedCap database. So it's easy to operate and easy to collect and to see the outcome of the patients in that database. But unfortunately, while we talk about the data of the rheumatic fever from the Pakistan, from the all sites, we lack that in a national registry. It's difficult to make a registry, and I think it's very important to identify the mortality rate. First, we should have a registry of all the diseases, and from all the sites, from all the provinces, so even from the small towns which are providing the care to the cancer patients, cardiac patients, any patients. So they are diseases, but they are unidentified.
Okay.
Yeah, so quickly, I think at least within critical care, I know that there's some move to creating a national registry for pediatric critical care units across the country. So hopefully that'll happen. I will tell you that countries like Brazil and Kenya have really good national level registries that they can you can extract data from about any patient, about any disease condition. I think hopefully at some point in the future, we can all get there in Pakistan, but all of you have to push for that.
Okay, thank you very much, respected speakers. Thank you, Nasra, for joining. So in the end, briefly, Dr. Muniba Jalil, she's our pediatric intensive care fellow. She will briefly tell you about the few of the projects which we're doing in ICU before breaking for lunch. Thank you.
Assalamualaikum everyone, and a very good afternoon to you all. I am Dr. Muniba Jalil, fellow in Pediatric Intensive Care, F2. I don't have there is no conflict of interest. All information used have been obtained and utilized for only informed consent and approval, after approval. Our first audit was like to improve the waste segregation compliance in our ICU. As everyone knows, and they know that the patient, or most of them in critical care, we focused on patient care and most of the procedures and to prevent the infections to our patient. But no one focused on to prevent the waste segregation and why it's vital in our critical care. The waste segregation is vital in sense of to prevent the infections to our patient. So this is a waste disposable guideline in our SKM. We have 4 bins. One is sharp. First one is of sharp container bins, in which we can dispose syringe, needle, cannulate, blades, broken glasses, and injection ampule. Other one is infectious waste. It's a yellow colored bin in which we discard dressing, catheters, stoma bags, gloves, drainage bottle, IV tubing, beers, and blood transfusion sets and bag. Other was cytotoxic waste, that is red in color, chemotherapy bottles, IV tubing used for chemo, and bottles wrappers are also discarded in red one. White one was used for household waste like tissue paper, cardboard, and kitchen refusal. So we have usually done audit in quarterly basis in ICU. So the problem identified in the last quarter of 2024 after October, that we have declined our ICU compliance from 100% to 90% to 68%. So it was the key problem area in our ICU. So ICU compliance was decreased into 60% in 2024 October. So major gaps that has been identified, that most of the we have new staff here. There's less of awareness regarding the cytotoxic waste and infectious bin. They have confusion regarding infections and household waste. So what we have done in our ICU to improve our compliance, our target was to achieve from increase our compliance from 68% to at least 90% within the target period of 3 months. What we have done, we have educate our staff during morning huddle time to differentiate what is infectious waste and what is household waste, and how to discard the sharp discarder if it is filled from 2/3 of that. So gradually our ICU compliance was increased from 68 to 94% to 95 and 100. And
in the start of June, and still is it decreasing, but still it is in the area of partially met, but we still not met criteria. Other was to introduction of extubation checklist in our ICU. First of all, before implementing a checklist, we have done an audit before implementing this to assess compliance of safe extubation practices in pediatric ICU. The aim of this quality or audit to at least to establish some protocol to standardize extubation readiness or assessment and some documentation in our pediatric ICU. The material and method that have been used, it was to in pediatric oncology patient, we have used the HIS. We have the retrospective data we have taken from HIS from the month of March to August in year of 2024 that has been analyzed. There are certain complications that we have seen in our audit, that to see the failure immediate need for reintubation within 24 hours of period, to see the post-extubation stridor, to damage to our larynx, or if there is any severe and forceful coughing that leads to a laryngospasm, or there is sign of aspiration, hypoxemia, or respiratory arrest. Total number of patients over the period of 3 months in retrospective study was analyzed was only 13 patients that have been admitted in our pediatric. 7% patients where there was reintubation trolley was ready. So the post-extubation compliance has been noted in our out of 16, 2 patients have post-extubation some complication. The form of that one patient suffered an episode of bradycardia after extubation, but rhythm was sinus, and therefore there was no intervention has been required at that time. So patient was managed conservatively. Another patient having MR number of 240634, he was reintubated within 48 hours of extubation due to fit and apnea. So this was out of 16, so 2 patients were reintubated within, 1 patient was reintubated within 24 hours of extubation. So the things that we have introduced on a pediatric ICU was to ensure the extubation checklist in our HIS manual. The extubation checklist, I can show you that our extubation checklist that has been in our HIS now. The points that are in that extubation checklist was to see the preparation, pre-oxygenate the patient at least 100% for at least 3 minutes to check NPO status, to at least ensure that sedation has been stopped, that suction is working, intubation trolley is ready, and need of adrenaline nebulizer has been ensured or not. The test that has been make sure to check before extubation is that to check cuff leak test, to check cuff and gag, GCS reviewed, or assessment of secretions has been reviewed or not. And then later on to perform extubation. So surprisingly, after that, introducing this extubation checklist, we don't have any known complication has been noted after that. The third project was to assess the 10-year of institutional study on CRRT practice. It was also a retrospective study. The data analyzed, as most of us know that the AKI is the most common in our pediatric oncological patient that is requiring pediatric critical care admission, requiring most of time CRRT. So the 10-year data has been, the aim of the study was first to see the indication, prognostic factor, and outcome in pediatric oncological AKI patient who require CRRT. So we have conducted the data from the year of 2014 till 2024. 10-year data has been conducted in our study. So most of the pediatric patient has been included in our study, dated having age of 1 year till 18th of year. Some CRT modality that has been used in our study was CVVH, CVHD, and CVHDF that has requiring CRT devices. Outcome has been analyzed in the form of primary outcome and secondary outcome. So statistical analysis has been used, data has been collected and has been placed in SPSS 27 module. These are the demographic findings. The total patient that has been recruited in our study was 114 patients. Out of them, 114 patients in which they have seen the age, gender, weight, body surface area, and duration of symptom with baseline creatinine and need of vasopressor has been used or not, and the number of need of vasopressor has been used or not, and the bicarb at the start with use of nephrotoxic drug. The data has been seen in the form of non-survivor and survivor. We have total 114 patients that has been included in our study. Out of them, surprisingly, 64% means 74 patients died. Survivor was only 40%, but that is 35%. Age, the median age of survivor was 4.5 years. Other things that has been used to need of vasopressor has been used during CRRT or not on chemotherapy agent that has been used. Renal disease, the most of them that has requiring CRRT was most of baseline diagnosis of AKI before shifting to ICU, and the non-survivor, most of that the non-survivor has TLS, but the survived patient, out of them, out of 34%, the patient who was survived were having baseline diagnosis of TLS. We have, unfortunately, out of 114, we have 2 nephrotic patients who landed in ICU but requiring CRRT, but both of them died during CRRT. Outcome was analyzed in the form of like sepsis, TLS, cause of mortality has been analyzed in the form of sepsis, TLS, and other has been also used. The pediatric patient who has been in our ICU, that out of 114, most of them have a primary diagnosis of lymphoma, Burkitt lymphoma requiring TLS. Other was non-significant like minor tumors, Wilms tumor, Yorkshire tumor, PBL, and osteosarcoma. 115 pediatric oncological patient में 64% did not survive, only 35% survived. So that patient who are not survive out of 64%, most of time were having oncological complication, having baseline sepsis with requiring CRRT. So they died. So leading cause of death was sepsis, followed by TLS and its complication. And primary diagnosis में lymphoma was the most common diagnosis at 51% of the patient having lymphoma, and 66% mortality was associated with lymphoma. Our study highlight that importance of CRRT in pediatric oncological patients and its findings, and we have to detect at least early sepsis so that this patient can be preventable before going ICU and having need of CRRT. So this was our study.
So what was the duration of starting the CRRT from the presentation? And secondly, what was the most common organism? Did they die? They developed the sepsis before starting the procedure, or they developed sepsis after the procedure?
So very nice question. The most of the patient, the duration of symptom of non-survivor and survivor before starting CRRT was they have baseline symptom before 3 days or 2.5 days ago. The non-survivor has duration of symptoms was 3 days back, and we have also assessed the duration of CRRT starting. So it was also mentioned in our study that they have timing of initiation of CRT was above, most of them have delayed. The patient who have most of them who are not survived, their CRT was started after diagnosis of TLS. It was delayed from 6 hours to 8 hours before due to insertion of Shaukat.
Thank you so much. You can have your question answers in the lunch session because we need to start our next session at 2 p.m.
Thank you very much for a very nice interactive and oncocritical care session. We'll break out for lunch, and the next session is going to start at 2 o'clock. Thank you very much.
Thank you everyone for coming. So today we're going to to start with our third session of pediatric oncology. So I would like to introduce the chair for the session. So we have Dr. Irfana Ishaq Hindu, who is a consultant pediatric hematology oncology at Shaukat Khanum Hospital, Lahore. And then we have Dr. Safia Khan, who is a consultant oncologist and BMT lead at PKLI Lahore. Thank you.
Assalamu alaikum. This is the last session of the Pediatric Oncology, Innovations in Treating Pediatric Hematology and Malignancies. Today, my first speaker is Dr. Tariq. Professor Dr. Tariq Ghafoor is the pediatric hematologist and oncologist. Currently, he is serving as a commandant of the Bone Marrow Transplant Center and leading education and training initiatives in pediatric bone marrow transplantation in Pakistan. He is talking about pediatric myelodysplastic syndromes in Pakistan.
आप बुलाएंगे मैं इधर अच्छा ठीक ठीक है सही है Thank you very much. I will just quickly go through the myelodysplastic syndrome in children. There is no conflict of interest. So myelodysplastic syndrome is basically a clonal disorder which is characterized by the disordered cell proliferation and impaired differentiation, leading to cytopenias. And there is evidence of clonality by genetic abnormalities or somatic gene mutations. Dysplastic cytological morphology is the hallmark of MDS, and the risk of transformation or progression to AML is there. So this is a very rare disorder as compared to adults. Less than 5% of the pediatric hematological malignancies, they can be categorized as a myelodysplastic syndrome. Annual incidence is 1 to 2 cases per million. And childhood MDS without excess blast is the commonest, making more than 50% of the cases. Although the median age of diagnosis is approximately 7 to 8 years, but it can present at any age. And male to male female ratio is approximately equal. The development of MDS is influenced by several factors such as genetic mutations, recurrent somatic mutations, and genetic predisposition with the several inherited bone marrow failure syndromes as Schwarzman, diamond blackfan anemia, Fanconi anemia, and environmental triggers. So this mainly play a role in the adult MDS, but they can play a role in the pediatric MDS as well. So advancing age, MDS is primarily a disease of elderly more than 70 years. And in the essence, MDS often arises from a combination of genetic susceptibility and exposure to external triggers, leading to clonal stem cell disorders. I will just go through the comparison between the adult and pediatric MDS. So it's very common in the elderly, more than 70 years in adult, and the pediatric, it's very rare disorder, less than 5% of pediatric malignancies, and more common in children less than 2 years of age. It is strongly linked to aging and cumulative DNA damage in adults, and it is linked to inherited genetic syndromes and bone marrow failure in children. And the subtypes of classification as in adult is not applicable to the pediatric MDS. Clinical presentation depends upon the symptoms of cytopenias in elderly, and it is often a differential diagnosis during workup of the inherited bone marrow failure syndrome in pediatric patients. There can be physical abnormalities that are associated with inherited bone marrow failure. And the key genetic abnormalities include complex karyotyping and specific somatic mutations in adults. And monosomy is the commonest genetic abnormality in children. And the differential diagnosis include the other causes of cytopenia such as nutritional deficiencies. And in the pediatric age group, it's most of them, they are inherited marrow failure syndrome and can be acquired aplastic anemia. Treatment is supportive in the adult, and bone marrow transplant is the primary and the curative treatment in pediatric patients. So just a summary is a predominantly distinct clinical entity, and in the adults, the diagnosis of exclusion, and in the pediatrics is the inherited bone marrow failure syndrome presenting as MDS
is the commonest. Monosomy 7 is hallmark of pediatric MDS. Refractory cytopenia of childhood is the prototypical subtype. And distinct treatment approaches with the transplant. Though both are stem cell disorder resulting in cytopenia and risk of leukemia, pediatric MDS is fundamentally disease of genetic predisposition and development, and whereas adult is a disease of aging and acquired genetic damage. So how we establish the diagnosis of MDS so diagnostic criteria minimum at least two of the following should be met: sustained unexplained cytopenias, at least bilinear morphological myelodysplasia, and acquired clonocytogenetic abnormalities in hematopoietic stem cells, and blast increased around about 5%. So if you classify the categories, they are myelodysplastic, myeloproliferative diseases such as JMML, CMML, BCR, ABL negative CML, then myeloproliferative related to Down syndrome, yes, TAM, and myelodysplasia of Down syndrome. And myelodysplastic syndrome, they are basically three categories, subcategories: refractory cytopenia with the blast less than 2% in peripheral blood and less than 5% in the marrow. Then anemia with excess blast, with the blast are 2 to 19%, and more than 20% is transformation to the leukemia, AML. There are certain conditions, as I mentioned earlier, inherited bone marrow failure syndromes, then GATA2 hypoinsufficiency, then SADM mutations, familial non-syndromic MDS, and the other familial where the family member may be having MDS. And the acquired condition can be because of prior chemotherapies, especially the etoposide-based chemotherapies, prior radiotherapy, acquired aplastic anemia. So the alkylating agents, as I mentioned, the etoposide, radiation therapy, they can all result in the acquired MDS. So clinical features basically they are variable depending upon the 1/3 of the patient, they are asymptomatic and they come to medical attention because of incidental finding of cytopenias. And the symptoms are usually related to cytopenia, for example, pallor, bruising, common as we see in the other leukemias as well. And in contrast to adults who frequently present with anemia, children typically present with thrombocytopenia and neutropenia. Lymphadenopathy and hepatosplenomegaly are uncommon, and if they are present, they are usually associated with advanced disease. So differential diagnosis depends basically. The dysplastic feature may be seen in other non-MDS diseases such as immunological disorders, rheumatological disorders, metabolic, and some degree of with the nutritional disorders, viral infections, and the inherited bone marrow failure syndromes. And it's difficult to distinguish between hypocellular refractory cytopenia of childhood from acquired aplastic anemia. Then ring sideroblasts are observed in pediatric patients with concern for bone marrow, MDS or bone marrow failure. Search for other categories, etiologies such as the nutritional deficiencies. And it is very rare in children. So investigation are required to basically confirm the diagnosis of MDS, exclude other causes of pancytopenia, exclude inherited bone marrow failure syndromes, screen for underlying cause, and document coexisting abnormalities. Hemoglobin level and red cell indices, if they are microcytosis, you need to look for the folate deficiency, B12 deficiencies, inherited marrow failure syndrome. And microcytosis and ring sideroblast is unlikely to be MDS. And normosity can be with anemia of chronic disease. Then white cell count can be increased, can be decreased. Then blood film for morphological review of the RBCs and WBCs. Evaluation of underlying syndrome, such as the hemoglobin, fetal hemoglobin can be increased in MDS, GMML, inherited marrow failure syndromes. And screening tests to exclude other diseases, chromosome fragility test for phencylanemia, telomere length measurement for dyskeratosis, erythrocyte ADNA to rule out diamond black fan, and chest X-ray and ultrasound abdomen to look for the inherited marrow failure associated anomalies. vitamin B12 and folate levels, flow cytometry for PNH. Immunodeficiency sometimes are also associated with the MDS. Or definitely marrow is required to document the dysplasia, and then immunological studies for CD34, 61, cytogenetic and karyotyping, and fish-based or NGS-based molecular studies. Additional tests may be required for the neutrophil function, the platelet functions. These are just a few pictures. Severe hypoplastic bone marrow in aplastic anemia. And then the mild hypocellularity and patchy bone marrow in refractory cytopenia of childhood. And then it can be hypercellular marrow with multilineage dysplasia. So there are two main categories basically. One is the refractory cytopenia of childhood with low blast, where the blast is less than 2% in blood and less than 5% in the marrow, and with the excess blast, with the blast percentage increase more than this number. So treatment is basically three main treatment strategies: wait and watch, and immunosuppressive therapy, and transplant. It depends upon the diagnosis and clinical scenario. So supportive care is the most one of the essential component of the treatment. So remove the cause if there is any underlying marrow dysplasia because of some medicine. Supportive care for blood and platelet transfusions, antibiotics. Leukodepletion is required, and if available, radiated blood cells should be transfused, and minimize the number of transfusion. So HB is usually maintained more than 7 gram per deciliter. Radiated granulocytes can be given in life-threatening infections. And platelet transfusion, we usually recommend not to give platelet transfusions if the child is not bleeding. But in case of fever or as then the child is bleeding, then we need to give the platelet transfusions. And the curative treatment is the transplant. So it depends upon the refractory cytopenia of childhood. We will recommend wait and watch. If this is without high risk of cytogenetic abnormality, suppose there is no monosomy 7, there is no need of transfusion, there is no severe neutropenia, you can go for the wait and watch policy. Because these children can survive for months to sometimes years without any intervention. And if there is any progression, then you need to proceed to transplant. And these children can be offered ATGs, corticosteroids, and cyclosporin, and may be effective in some patients. And the RCC remain risk for progression to leukemia. About 30% they progress to leukemia over 5 years. And for these patients, transplant is the best available. With the best available donor is the recommended treatment. So transplant remains the only curative treatment for refractory cytopenia of childhood, but the optimal guidelines for the chemotherapy before transplant, they are controversial. So HLA should be performed as early as possible to expedite the donor search, and transplant is recommended if there is matched family donor with and significant cytopenias. Pre-transplant chemotherapy is usually not indicated in refractory cytopenia of childhood. Myeloablative conditioning are used, but the RIC conditioning they have been used as well, especially if the case is the hypoplastic marrow. And the MDS with excess blast, transplant remains the standard of care and should be performed as early as possible. And cytoreduction prior to transplant is again debatable here, but it depends upon the blast count, risk of progression, cytogenetic, donor availability, and estimated time to transplant. Role of chemotherapy, if this blast count is less than 9%, it's controversial. If it is between 10 to 19%, then we give the AML type chemotherapy to achieve the remission. Many centers give it, but sometimes it's not very helpful. And more than 20% should be treated as AML with full chemotherapy before going for transplant. Donor selection, matched sibling is the preferred donor. Conditioning regimen, as I mentioned, pre-transplant chemotherapy, myeloablative conditioning is recommended, but a reduced intensity can be given in hypocellular marrow. and graft-versus leukemia effect should be aimed in treatment of MDS as well. There are hypomyelinating agents, methylating agents, especially used in adult, azacitidine, decitabine. They are not curative, and they are not routinely recommended as a curative treatment in pediatric MDS. And then there are the thalidomide analog, then thrombopoietin receptor agonist, eltrombopag. They have been used in adults. And none of these agents have been extensively studied in pediatric MDS. MDS in Down syndrome is they have, as you know, the Down syndrome patient, they have an increased risk of MDS and AML. But they are very responsive to treatment, such as the transient abnormal myelopoiesis. Sometimes it's self-limiting and it settles down in a month or so time. And it is highly sensitive to chemotherapy, especially cytarabine-based chemotherapy. And the underlying genetic syndromes management, it must be integrated with the management of underlying syndromes. Prognosis outcome has improved significantly with the transplant. Long-term survival is now 60 to 80%, depending upon the subtype, cytogenetic and donor type, and complications. So there is increased risk of disease progression to leukemia, especially with the monosomy 7 and the complex karyotyping having more than 3 abnormalities. And the international prognostic scoring system is less valuable in children. 2 or 3 lineage cytopenia and blast more than 5% are associated with the bad prognosis. So, as I mentioned earlier, hypocellular marrow with the low blast, they can remain stable for months to years. And if this is a study from, it's showing that the matched sibling donor with the family donor 50% long-term survival after 3 years, and matched unrelated 35%. And with the secondary MDS is less than 30%. So survivor, basically, they need to be kept under surveillance for chronic GVHD, endocrine disorders, organ damage, and secondary cancers. So I will just share what we have been doing for these disorders at AFBMTs for the last about 10 years or so. So there we have done transplant in 27 patients in the last about 10 years. So there was 14 AML patients and 10 MDS patients and 3 were JMML patients. So these AML patients, they were 6 cases was resistant, mean they did not achieve remission after induction chemotherapy. Relapsed cases 4 patients with high risk cytogenetics such as FLT3 mutation, there were 4 cases. MDS, hypoplastic MDS were 5 patients, with excess blast 2 patients, and with transformed to AML were 3 cases, and 3 cases of JML. So for AML, we use the D3A10 chemotherapy. If these patients, they were refractory, so they had FLA chemotherapy, then FLA chemotherapy, and then went to transplant. AML evolved from MDS. These patients received 2 to 3 cases of azacitidine and venetoclax, and after achieving blast less than 5% or 1% in the marrow, they were taken to transplant. Similarly, MDS with excess blast, hypoplastic MDS, they were just kept on supportive care, no chemotherapy was given. And JMML patients, they were for the cytoreduction, we used different modalities such as mercaptopurine, methotrexate, and the low dose cytarabine 20 milligram daily for 5 days per week for maybe 2-3 weeks. So mean age of diagnosis was about 9.7 years. There were 13 female and 14 male, about almost 50% each. So donor were sibling. 1 transplant was done with the father. Conditioning was used, myeloablative conditioning, all of these patients, busulfan, cyclo, and melphalan. GVHD prophylaxis was cyclosporin and methotrexate. So bone marrow was the main stem cell source. 1 patient had PBSC, and the TNC dose was 4.5, and CD34 was 7.5 almost. Engraftment mean time was 12.86 days. So 7 patients they had treatment-related mortality making about 26%. 5 patients relapsed, and 15 patients, they are disease-free. So out of these 5 relapses, 4 patients died ultimately, and 1 patient is alive. Overall survival is 60%. So if you look at the causes of mortality, there were 4 relapse-related mortality. 7 was TRM. 2 out of them, they had sepsis. 1 has GVHD. 1 had veno-occlusive disease. 1 died of extensive GI bleeding. 1 had primary graft failure, and 1 patient has TATMA. These are just the graphic representation. So MDS, if you look at the disease-free survival, MDS is 60%. AML relapse and refractory, they have 57%, and 33%. Only 1 out of 3 JMML, he survived. And this is the overall survival, because 1 AML patient is surviving after relapse. So that's it. So MDS is rare in pediatric population, and inherited bone marrow failure syndrome should be excluded. Most common subtypes are refractory cytopenia of childhood and MDS with excess blast. And definitive diagnosis may require repeat, because I have a girl recently, she was diagnosed after about 8 months. She had 2-3 bone marrows. Initially, it was reported as fibrosis, and then about 2 months ago, she was diagnosed as having MDS. And next generation sequencing can help us in establishing the mutations in these patients. Transplant remains the only curative treatment. Thank you very much. Thank you.
I am pleased to introduce Dr. Ahmed Naqvi. He is pediatric hematologist oncologist with special interest in leukemia, lymphoma, and HLH. He is currently working as assistant professor in Shaukat, Canada, and he has served as director of hematology oncology education program there as well.
All right, thank you very much. And yes, thanks to the organizers for getting me here. It's always a pleasure to meet friends and make some new friends as well. Do I have only 20 minutes instead of 25? That will not suffice for my talk. So the topic that I was given is peripheral T-cell lymphoma. So as you know that about 120 to 150 per million children get one or the other type of lymphoma of cancer every year. And the major chunk, of course, is leukemias and lymphomas. So lymphomas overall are about 11 to 12%, and they are mostly basically divided into Hodgkin's and non-Hodgkin's. Today, we are concerned with one of the non-Hodgkin lymphomas. So those are like 7% of all cancers that we see in pediatric age group. And we can divide those pediatric non-Hodgkin lymphomas, or even adult one as well, in precursor and mature. So what does precursor means? That those lymphomas or leukemias, basically, they arise from bone marrow or thymus. The ones that arise from the post-thymic tissue, they are known as peripheral lymphomas or mature lymphomas. So then in precursor lymphomas, the commonest one, of course, is T lymphoblastic lymphoma, 15 to 20%, and a minority is B lymphoblastic lymphoma. When you come to the mature lymphomas, there are B and T again. We are not talking today about B, so we will just concentrate on T mature cells, lymphoma. The commonest and the most common nodal variety is anaplastic large cell lymphoma. That's about 10 to 12% of all lymphomas. The non-anaplastic variety, the commonest is PTCL, that NOS, that is not specific ones. So that is what we are going to, we will try to address those two things, not otherwise specified is NOS. So WHO recently in 2022 actually came up with their 5th edition of classification of lymphoid neoplasms as well. That is a very long list. There are more than 30 types of mature lymphomas, T-cell lymphomas. But this is a simplified version of that. So that has been divided into nodal, extranodal, then leukemic, systemic, or the cutaneous. Those are 4 main varieties. The ones that you see in red are seen in pediatric age group, whereas those which are in black, they are either not seen in pediatric age group or there are just like some small case reports. So anaplastic large cell lymphoma, I already mentioned, 10 to 15%. There are 4 distinct varieties: ALK positive ALCL, ALK negative ALCL, breast implant one that is seen only in adults, and then CD30 positive cutaneous lymphomas. Some of them we see in pediatrics. Now, 95% of ALCLs in children and adolescents are ALK positive. The median age that you see this type of lymphoma is about 12 years. And it is a disease which actually presents with advanced stages. So most of the patients will have grade stage 3 and 4 disease. Bone marrow involvement is seen only in less than 10% patients. CNS involvement is even rarer. About 70-75% of patients will present with B symptoms. And this is a very immunoreactive type of lymphoma. So they will present with hyperinflammatory syndromes, and some of them will even have frank HLH. But some patients, they have a waxing and waning type of a picture that's there will be B symptoms with the large lymph nodes, and then they will settle down on their own without any treatment for maybe a few weeks, just to come again with the same symptoms till the time that they frankly, like the disease doesn't go away till the time that you start treating them. These are the sites of anaplastic large cell lymphomas. The commonest, of course, are the lymph nodes, but extranodal tissue is also involved, as you see that is skin, lung, liver, etc. There are varied types of morphological pictures here. I have just shown 2 of those, but there are usually 4 of them they are described. And these morphological types also have some prognostic impact that I will show you later on. The main thing that there's these cells that you see here. This one is working. Yeah, these are the known as the hallmark cells, and they are of different shapes. Like here, this is the donut shaped, this is kidney shaped, and then this is horseshoe shaped, and this is the reed stem type of cells that you see in Hodgkin's lymphoma. So, and then when you come to immunophenotyping, they are all CD30 positive, and most frequent T-cell associated antigens are CD3, 5, and 7. But some of those patients, they don't have any of the T-cell markers present. So that variety is known as null cell phenotype. CD15 is usually absent, as you know that in classic Hodgkin's lymphoma, they are CD30 positive, but CD15 is also positive in those cases. Most cases, they express and EMA and CD25. EBV is negative in ALCL. And this is ALK positive cases are because of the fusion of nucleophosmin 1 and anaplastic lymphoma kinase translocation, that is translocation 2,5. ALK negative, it is indistinguishable, presents the same way, advanced stage disease, but they don't have ALK positivity. That is the only thing. But other than that, there are some difference in the most frequent cell markers that you see. Now, coming to the treatment, this lymphoma is very chemosensitive, upfront and at relapse as well. And there are many different protocols that have been used. But again, the most important thing to look at is that the event-free and progression-free survival is actually within like high 60s or 70%. Initially, the protocols that were used were BNHL, BFM type of protocol. But then in early 90s, APO protocol came up, which is vincristine, prednisone, and adriamycin. And I will describe some of those protocols in a little more detail, just to make, yeah, sorry. So this is the EPO protocol, where induction for 4 to 5 weeks was vincristine, prednisone, and adriamycin, followed by 15 cycles of other chemotherapy that's given here. But here the vincristine was given every 3 weeks. Then Children Oncology Group, they did a study where they compared giving vincristine every 3 weeks with giving vinblastine every week. So what they saw was that the outcome of the two arms was the same, but there was more toxicity in the vinblastine arm, and the protocol was actually stopped in between because of that. So with APO, your event-free survival or overall survival was somewhere around 75 to 80%. The next protocol, and that used to be the standard of care, actually, APO. Till the next protocol, this anaplastic large cell lymphoma 99 protocol was introduced, that remains the standard of care even now. So here you will see that there is a prophase with 6 cycles of, they are alternating cycles, 1, 3, 5, and 2, 4, 6. The methotrexate and dexamethasone is given in both of those alternate cycles, but in 3 cycles, it is ifosfamide, etoposide, cytarabine, and then the other 3 get cyclophosphamide and doxorubicin. This is actually a 10-year progression-free survival and overall survival. Here you will see that overall survival has gone up to 90% with ALCL type of chemotherapy protocol. Then it was seen, because there were adult experience, that brentuximab actually has improved the outcome in these types of lymphomas. So this is a pediatric oncology group study where with the backbone of the same ALCL protocol, they used 2 arms. One arm got brentuximab and the other arm got ALK inhibitor crizotinib. So they reported the outcome in 2 different articles. So this is the one which with the brentuximab arm. Here you will see that the event-free survival went up to 80% and the overall survival went up to 97% with brentuximab. The other arm, so this a little bit about the ALK inhibitor. The crizotinib that they used is the first generation ALK inhibitor. Then you have second generation and third generation. These are usually used in more advanced disease. There are some studies about the second generation also with alectinib and ceritinib. There is an ongoing trial going in pediatrics about the brigatinib, and loratinib is only one case report, but it is very useful if there's a CNS disease. So this was the crizotinib arm, and here you will see that it is the same, almost 77% EFS and 95% of overall survival. But the problem here was that the crizotinib arm, 20% of those patients had thromboembolic events. So it was too much of toxicity. So their recommendation was to use brentuximab arm only. And this also study was actually terminated in between. Then the Chinese actually came up with a risk stratified treatment. They used the NHL-BFM backbone that I will show you in a while. And then the objective for them was to see if what were the prognostic factors. So they looked at the morphology, the common morphology, lymphohistiocytic, small cell, and Hodgkin-like. And they had one of the things that was identified was the minimal disseminated disease. So there are ways of doing like or detecting minimal disseminated disease in like COG protocols or others. That is just like morphology and immune phenotyping. Here they used RT-PCR for that. And the results that you see, this is the protocol that they use. So this is then the increasing intensity actually. So the least intensive is the A protocol, and then it goes on and on up to the CC protocol. So they risk identified, and the low risk patients were only those who were stage 1 and 2, and they received only AB and AB. These are the 4 cycles. So the least intense protocol. The high risk patients were those who were stage 4, and there were involvement of different organs, plus the morphology was small cell or lymphohistiocytic morphology. Then positive minimal disseminated disease. So they received the highest intensity chemotherapy, and in between was the intermediate risk. Those were stage 3 patients. So what the results were here is 77 or 78% of the event-free survival and 92% of the overall survival. And when you look at, according to the stage, this is for stage 2 is 100% event-free and overall survival. For stage 4, it is 65% event-free and 85% overall, and in between was the intermediate risk group, the stage 3. But then they also saw according to I will come to that later, but they also saw the minimum disseminated disease. This is our protocol that I mentioned. They had 2 arms of the children oncology group. So those patients who had minimal disseminated disease positive had this outcome was worse than those who were negative. In both arms, brentuximab arm and crizotinib arm, both were worse where there was minimal disseminated disease. This is the Chinese protocol that I was just mentioning. Here also they showed very clearly that if you have minimal disseminated disease, the outcome is very poor. And this is the anaplastic large cell lymphoma also. So all protocols identified minimal disseminated disease as a negative prognostic factor. The other prognostic factor that was seen, as I mentioned, was the histology. So this is the Chinese paper. These are the patients who had small cell and lymphohistiocytic morphology, but the overall survival was almost the same for both. And this is the anaplastic large cell lymphoma, the largest study where there were 420 patients. Here, again, MDD positive patients, the poor histology patients, they had an outcome of only 50%. This is according to the risk group that I mentioned, risk group, the low risk, high risk, and the intermediate risk. So if you have the low risk or R1, so R1 were patients who had stage 1 and stage 2 disease only, 100% overall and event-free survival. Whereas those intermediate risk were about 90% and 95%. And the highest, the R3, where it was stage 4 and other high-risk features, the overall survival was almost 90%. Then there were many different, more refined ways of looking at minimal disseminated disease. So this is qualitative MDD by RT-PCR. This is RQ-PCR. So this depends on the copy numbers. Then you see this by digital PCR. So the more refined you go, then the outcomes always you see that if it is like by digital PCR more than 30 copy numbers, then the EFS is only about 35%. Whereas where the copy number is less than 30, it is 75%. Another factor that they saw was about the MRD before course 2. And the MRD, if it is positive, that is a very high risk group. And of course, their outcome is the worst. So what do you do with the relapsed or refractory patients? So this is a multi-center retrospective study. This was just published earlier this year. Patients less than 21 years of age, there were 87 patients. These were the treatments that they had actually received initially. And those are the treatments that they received just before the transplant or after when they were diagnosed as relapse. So you will see that more than 90% of patients, they received brentuximab and ALK inhibitor in combination or separately. So what does it show? Let me just go to the next one. So this was for the relapse patient for the whole group. This was the event-free survival and 91% survival still for patients who were relapsed. So this lymphoma, anaplastic large cell, gives you very good results. These are the transplant results. So those who had a patient, there was no difference between allogenic transplant or anaplastic transplant. Or autologous transplant. So what are currently what's going on? These are the current trials in pediatrics for initial treatment. They are looking at, those are those who are low risk for relapse. So stage 1 to 3 disease, just monotherapy with vinblastine, 24 months of vinblastine therapy. And this is the second generation ALK inhibitor, alectinib. This is a combined study in adult, pediatric, and teenage patients. And these are the ongoing trials. For relapsed and refractory patients, this is again crizotinib, the post-marketing trial. This is brigatinib, as I mentioned. This is again a second generation ALK inhibitor. And this study with nivolumab has completed recruitment, but the results are not out as yet. So what are the recommendations for anaplastic large cell lymphoma? Based on prior trials, stage 2 to 4 should be treated as per ALCL 99 with the addition of brentuximab if it is available. Okay, thank you very much. Then for relapsed and refractory patients, there is reinduction with an ALK inhibitor, especially a second or third generation inhibitor. So for relapsed or refractory patients, one should use a second generation or third generation, especially if there is a CNS involvement. The third generation ALK inhibitor is the most useful one. Stem cell transplant of course, these factors need to be considered, like timing of relapse, extent of the disease, donor availability, etc. And for patients with late relapses, that is more than 1 year from diagnosis, weekly vinblastine for 2 years should be considered and has given actually good results. Now, changing gears to the other lymphoma that I mentioned, it is the peripheral T-cell lymphoma, not otherwise specified. So this is a rare one, but in non-anaplastic variety, this is the most common one. Less than 2% of children, more common in males, and the ages that are mentioned there. So there is higher incidence with pre-existing medical conditions like immune deficiency, chromosomal breakage syndrome, hyperimmunoglobulin E syndrome, etc. So this is a diagnosis of exclusion, actually. When you cannot diagnose anything, then you will diagnose PTCL NOS. So this is a bucket which the pathologists they will put into. And these are different histological varieties, the small cell varieties, with some of them have these histiocytic infiltration there. So, but this has nothing to do with the prognostic factors as well as you see in anaplastic large cell, ALK positive anaplastic large cell lymphoma. So here the cell of origin is often CD4. They are CD4 positive T cells, but cases can be CD8 positive, double negative, or double positive. And pan T cell markers are usually positive. CD30 expression is variable, so not necessary that in all cases you will get that. Then as far as molecular features are concerned, in pediatrics, it has not shown very clearly, but in adults, it has shown that those patients who have this fusion, PTCL TBX21, they have a worse prognosis, they have a better prognosis as compared to those who have PTCL GATA3 mutation. They have the worst prognosis. In pediatric age group, these are the mutated genes seen, but nothing is prognostically significant if you find them. So again, the clinical presentation, it presents with advanced stages, and there can be diffuse involvement of peripheral lymph nodes, and they can actually present with pleural or pericardial effusions. These symptoms can be there. CNS involvement is even rarer. And with this PTCL NOS, HLH is more common, and similarly the other hyperinflammatory symptoms. The prognostic factors, advanced stage, presence of pre-existing conditions, significance of biological factors identified in children, as I said, we don't know as yet. So what about the treatment? The problem here is that the treatment has not improved outcome, and this is although in children, the outcome is better than that is in adults. This is an adult study where they had used anthracycline containing regimens, mostly CHOP. So CHOP is the drug is the protocol of choice here. And here you will see that in almost more than 340 patients, the overall survival was only 32%, and event-free survival was 20%. But again, this is what they thought, that if you add etoposide to CHOP, the outcome is going to be better. So this is for the whole cohort, and this is only for ALCL, ALK positive ALCL, but all the other mature lymphomas, it remained almost about 50%, not more than that. This is the overall survival, same results. This is actually this is addition of etoposide, and this is the regular CHOP 6 cycles that they give. So the addition of etoposide actually improved the outcome in those patients. And this is non-ALK positive ALCL. So this is with etoposide, this is without etoposide. Now, these are the published experiences of other biological agents with CHOP. So these are all the combinations mostly used in adults. It's not is mostly in pediatrics. So there are phase 1 to phase 3 studies. This is the largest study that you see. But here, out of those 226, there were only 29 patients with PTCL-NOS, and with those who got brentuximab with CHOP minus the vincristine, and this is the CHOP. So as it is a mixed group, so we do not know, but overall, if you see the outcome was better than the other protocols, but we don't know because it is a mixed bag. And these are other combinations that have been used in adults. Pediatrics, we don't know. So CHOP has remained the backbone for almost everything in this type of lymphoma. So what are we doing on here? So there are new agents under evaluation, duvecilib with or without other agents has been used, and with romidepsin actually has given good results. So we do not know about pediatrics, but duvecilib with romidepsin is giving good results. In pediatric, these are the studies that have been reported, Children Oncology Group, only 12 patients. So you will see the survival for any of those combinations. This is the largest experience here, and the event-free overall survival has not gone up with any of, this is our sick kids experience, not many patients, only 7 patients, but again. So if transplant will make any difference, this is a recent experience that was shared by European Bone Marrow Transplant Group, and they had 55 patients, 46 of them had allo transplant, 9 of them auto transplant. Out of the whole mature lymphomas, 38 were PTCL-NOS, 30 got allogenic transplant, and 8 got auto transplant. This is for the whole group. This is the event-free survival and overall survival. This is a median follow-up of 6.9 years. So what the conclusion was that data suggests that a role of allogenic stem cell transplant in patients with high-risk disease who reach at least partial remission after primary or relapse therapy should be done on those patients. But those patients who are refractory or who have a progressive disease prior to transplant, they do not benefit even with the transplant. So allotransplant, as I said, the role is debated, but all efforts should be made to put the child into at least some partial remission type of a thing. Transplant, it offers some of the GVL effect as well. So auto, again, it is controversial, but there are 2 randomized trials are investigating in patients who achieve a CR. And this is another trial. So 2 trials are going, one Japanese and the other. So what is the recommendation for this type of lymphoma, PTCL-NOS? That most used regimens include ALCL style therapy. European expert consensus guideline is to favor, and they favor ALCL style therapy. Role of HSCT remains undefined. And I think that is my last slide. Thank you.
Yeah. Thank you, Dr. Dr. Ahmed, for this comprehensive and updated talk. So question answers will be taken at the end of the session. The third talk is the virtual talk and start at 3. And there is the 5 minutes. In the minutes.
My question is for Dr. Tariq. What is your experience of secondary AML and MDS?
Transplanted any secondary AML. One patient was referred from Shaukat Khanum, but unfortunately she died during the chemotherapy. And MDS, no, not even MDS in transplant.
I have a question regarding the relapse ALCL because we normally do, I mean, what we're doing, we're giving a monotherapy of vinblastine. But what if even that fails, if there is a third relapse? So then what are the options? Do we take them for transplant? Will you consider that, or do we don't do that?
So, of course, I will do transplant. But the thing is that there should be at least some partial. Yeah, so you can use combination of ALK inhibitors. If you have not used brentuximab, use brentuximab. Your brentuximab also fails ALK inhibitor without any of the second generation ones. And you have seen that those patients who got a combination, they at least went into most of them actually they went into either complete remission or partial remission. So these changes they have used with chemotherapy as well, but we can try it with single agent.
So my question is, if a patient goes into remission, this is asking for a specific patient actually, with brentuximab, so progressed on ALCL 99, then progressed on vinblastine, went into remission with brentuximab. At that point, and there are no matched sibling donors, so allo is not an option. Would you take them to auto or just keep them on brentuximab? And if yes, for how long?
Sure, that the transplant and both cases. The role of transplant, of course, is debatable, but still, I think you can you just can continue on brentuximab. How many cycles? Usually 6 to 8 cycles are given, and but again, it all depends that what are you using with that.
As a mono agent, as a
monotherapy.
Yeah.
Monotherapy,
Like,
because
can you
brentuximab
continue
you
that
will give day 1 for 3 weeks, and after 3 weeks you can.
Right.
Crizotinib, if you are using, it is given daily for 21 days. So that is crizotinib is oral, and it is given for daily for 21 days, and then you will give a gap, and then you can start, as it was used in children oncology group protocol upfront, not relapsed.
So in terms of CNS disease at relapse, so this again specific patient had extensive CNS disease at relapse. So disease went into remission with intrathecal therapy and brentuximab, but we know brentuximab does not penetrate the CNS. So what would be the strategy for CNS control? Continue intrathecals, or would you consider craniospinal radiation? 3-year-old child.
The third generation ALK inhibitor is actually very useful. And
not available
because in primary CNS lymphoma as well, you can have anaplastic large cell lymphoma, primary CNS, not like systemic. So there also the third generation but I don't know if you don't have that, then your options are very limited.
So, but are you aware of anything comparing because there are some papers that talk about craniospinal radiation.
I have not seen that radiation thing. I have not seen that, but maybe I can ask and or look into the literature more carefully. I'll go and look at that.
Thank you. Thank you. Oh, any more questions? Okay, thank you. Next speaker is Professor Dr. Ajay Vora. He is the pediatric hematologist at Great Ormond Street Hospital. He has a special interest in childhood leukemia. He has taken a leading role in many clinical trials in childhood ALL and hematopoietic stem cell transplantation nationally and internationally. Today, he is talking about the de-escalation of chemotherapy for childhood acute lymphoblastic leukemia. Dr. Ajay, please share your screen.
Yes, I'm here.
Good morning.
Good morning. Palwasha, बहुत ही शुक्रिया हमको ये दावत दी आपने तकरीर में मुजलिस में बोलने की। तो अब मेरी उर्दू तो बहुत खराब है, तो मैं अब कोशिश करता हूँ मेरी स्लाइड लोड करने की। देखते हैं ये होता है कि नहीं।
Dr. Ajay, please share your screen.
Can you hear me?
Yeah.
You can hear me?
No. Yes, I hear you.
You
But
can hear
please
me.
share your
Yeah,
screen.
it's just I'm struggling to share. Let me just sort that out.
Okay.
Okay, can you see my screen now?
Yes, clearly.
Okay, great. Phew. Well, thank you again for inviting me. And so, as this slide says, I'm a consultant hematologist at Great Ormond Street Hospital, London. And I'm going to try and persuade you that although our outcomes for childhood ALL have improved over the last 4 decades, with overall survival in developed countries at least of approaching 95%, we still have issues which need to be resolved, which come in part due to how the treatment protocols have developed over the last 40 years in the absence of any new agents, where we have basically tweaked this original Donald Pinkel St. Jude's total therapy template with gradual intensification, an introduction of stratification, and newer formulations of agents such as the use of dexamethasone instead of prednisolone, pegylated asparaginase instead of native asparaginase. But with that has come certain cost, and that cost now needs to be addressed, because what these excellent outcomes have exposed is that we're overtreating a significant proportion of patients, resulting in a small but significant mortality, morbidity, which has an impact on quality of life and burden of care. So the first cost is mortality. We now, in developed countries at least, have as many patients dying of treatment as of the disease itself. Around 5% of patients are dying, usually from transplantation, but also current intensive first-line treatment protocols have overall a mortality associated with them of between 2 and 3%. Secondly, we are overtreating probably about 40 to 50% of patients. And this is a busy slide, so I'll talk you through it. In the UK, we did a trial called UCAL 10 back in the mid-90s, where we tested whether you needed to give post-remission intensification, because an earlier BFM study had suggested that it improved outcomes by nearly 20% EFS. So it was a 4-arm trial. The arms were A, B, C, D. A was an arm without any post-remission intensification. B and C had 1 intensification, either given early or late. D had 2 intensification. And you can see from this EFS curve below that the best arm was arm D, understandably, with a EFS of 71%. But the arm A, without any post-remission intensification, had a disease-free survival of 57%. So these 57% of patients don't need post-remission intensification. And that premise was tested in a COG trial published a couple of years ago as a letter in leukemia, which used two different post-remission treatment regimens, one of which did not have any intensification, and both had a similar disease-free survival approaching 98%. Now, this admittedly was for about 15% of the precursor ALL patients who were considered to be very low risk. But this approach can be further extended to other subgroups of patients. Secondly, we have considerable morbidity associated with our current treatment protocols. This is a legacy UK trial, UCAL 2003, serious adverse events. And you can see with escalating intensity of treatment, regimen A is the least intensive, regimen C is the most. You have an increased risk of serious adverse events with these significant p-values as you go from regimen A to C. And almost all of these serious adverse events are in some way, if not directly, then indirectly related to asparaginase and steroids, I would say. So those are the two drugs that you should bear in mind should be the focus of any de-escalation strategies. Now, this morbidity has an impact on quality of life, which we did measure in that trial at the start of treatment, end of induction, midway through treatment, around a year into treatment, and then at the end of treatment. And you can see that compared to the normative data, almost all domains of quality of life functioning plummet by the end of induction and recover towards the end of treatment, but even then have not reached the QOL measures that the patients and families reported at the start of treatment, just when they've been given this diagnosis of a life-threatening illness. So we have to bear in mind that there is this cost. And so moving forward, we need to find a way of de-escalating the treatment intensity. And there are various ways which we are testing in the ongoing as well as future trials. And the three broadly cover improved risk stratification such that you can identify more and more of these low-risk groups that the COG trial that identified. Now that we have got new agents, and I'm going to talk about one in particular, we should find a way of using them to not just add to the existing chemotherapy backbone, which is how it has been tested so far, but to actually replace elements of chemotherapy such that it reduces the mortality and morbidity. And then we should now move slightly away from having EFS as our only endpoint to overall survival, because at least in developed countries, we have access to non-transplant salvage treatment options for relapse. And these are highly effective and can be employed without an increase in mortality as seen with transplant. So the Altogether trial is a trial that includes the countries that are in orange or saffron or whatever you want to call it. It is going to start recruiting from Spain as well shortly, which is presently denoted in blue. And at that point, we'll be recruiting 2,000 patients per year from these 15 countries. And the age of recruitment extends to 45, but in most countries, it's up to 18, not to 45. In the UK, it's up to 25. So this trial is testing various questions, but one of the questions is de-escalation. And we've used an algorithm that was developed by Anthony Mormon based on legacy UK trial data, and then confirmed in a separate European data set. And if you're interested, it was published in Blood Advances in 2019. And this risk stratification integrates not just MRD, which everyone knows, when used with a sensitive quantitative PCR method, is the most powerful discriminant of EFS, but also traditional genetics, what we call cytogenetics, as well as copy number abnormalities. And I'm not going to go into the details of the formula, which, as I said, you can find in this paper, but this allows you to identify two relatively low-risk groups with a estimated relapse rate of under 5% and an overall survival of approaching 100%. On the other hand, it actually captures almost all the relapses, over 70%, within a intermediate high-risk group, which forms about 40% of all patients with a relapse risk of 15%. And for those of you who are wondering why this very high-risk group in the last row has a similar relapse rate, this 14% in the very high-risk group is with transplant in first remission, whereas this is in the IR high group without transplant. But let's keep our focus on these two relatively low-risk groups with a relapse risk of 5%. And what the trial is doing in these two groups, this is the low-risk group, and this is the intermediate low-risk group, is testing, admittedly, a very modest de-escalation of chemotherapy. Now, again, I'm not going to give you too much detail in the interest of time. You will find the information about this on the Altogether website. So moving on to new agents, I'm going to focus on the one that we have done some early work with in order to use it as a replacement for chemotherapy, and that is the bispecific T-cell engaging BiTE antibody blinatumomab, which, as everyone I'm sure knows, redirects T cells to target CD19 expressing lymphoblasts, and not only does it cause cytotoxicity, but also there's proliferation expansion. And so you have almost like an in vivo CAR T cells. And COG did a very important pivotal trial in standard risk, so NCI standard risk. These are patients who are under 10 and who have a white cell count less than 50 and who don't have high-risk cytogenetics. So this is your standard risk groups. There are two subgroups of them. Again, I won't go into details. You'll find all those in the paper, and I'm sure most of you have seen it. And it showed a benefit for blinatumomab in not only the overall cohort, but also the two subgroups with a disease-free survival approaching 98%. But importantly, in this trial, the blinatumomab was added to the intensive backbone. And that is why the incidence of infection was increased in the combination group, the blinatumomab plus chemo group, both the standard risk average, standard risk high. And this is likely to be due to the fact that the immune compromise associated with chemotherapy is exacerbated by the B cell aplasia, admittedly transient, that results in hypogammaglobulinemia and therefore possibly an increase in not just viral but bacterial infections. So this just is puts even more emphasis on the fact that although blinatumomab does improve outcomes when added to chemotherapy, its main role going forward should be to try and replace chemotherapy. And we had an opportunity in the UK of testing this in patients who could not tolerate chemotherapy, either because they had severe toxicity early during their treatment, induction or consolidation. And by the way, again, you'll see all the details in the paper we published in GCO in 2023, or had underlying a predisposition to toxicity conditions, which are listed on the left here. And we had 80 odd patients in the paper. We now have over 150 patients who've been treated with blinatumomab, given, again, it's quite complicated, either halfway through induction, halfway through consolidation, or post-consolidation, but replacing parts of the interim maintenance, plus minus delayed intensification. And you could see that there were three groups. One where patients, after receiving 2 cycles of blinatumomab, received maintenance alone, about 18 in the paper. There are now 30 overall. About 100 now who received DI and then maintenance because they had recovered from their toxicity. And we have a small group of patients who were considered high risk and went to transplant. And these are not in the case control analysis that is shown on this slide, which basically took 2 controls from the legacy trial I mentioned, UCAL 2003, matched them for the traditional risk factors with these cases, the 85 cases, and looked at the event-free survival. As you can see, the black line is that of the cases, the red of the controls. And at 2 years, and now we have 3-year median follow-up, the curves almost overlap, and possibly, but we need further follow-up, the cases have a slightly better event-free survival, so certainly no worse. Equally importantly, all the standard risk groups, cytogenetic high-risk groups, those with high MRD, those who are NCI high risk, either had a similar relapse-free survival or a better, the blue is the cases, or a better relapse-free survival than the controls. So important takeaway message, and this comes through from the COG paper as well, that the traditional risk factors for relapse in patients treated with chemotherapy alone don't seem to apply when you're using these new immune therapy treatment approaches. And this applies as much to CAR-T, by the way, but not so to inotuzumab, which I should just clarify, and the reason I'm not speaking about it is not immune therapy, because its cytotoxicity is mediated by the chemotherapy that the antibody targeting CD22 is carrying as a payload. So it is essentially targeted chemotherapy. It's not immune therapy. I think it's an important point of distinction that you should remember. The second important and interesting observation is that there were 12 patients who should have had a transplant because they had a very high end consolidation MRD of greater than 0.05%. Almost every protocol transplants these patients, but they could not for various reasons, either pre-existing morbidity or severe toxicity from which they hadn't recovered. And these 12 patients are now 20, and we've only had 1 relapse at a median follow-up of 3 years. Most of these patients should relapse early. So we are kind of confident that actually blinatumomab might even be a means of avoiding first remission transplants if given in the right way. So we're now testing this premise. Can blinatumomab replace parts of the intensive chemotherapy? And remember, the 2 drugs I mentioned, that I blame for most of the toxicity of current treatment approaches are pegylated asparaginase, and especially pegylated asparaginase given post-induction. There was a trend, which is reversing now, fortunately, in developed countries of asparaginase intensification with St. Jude's, the NOFO group, the BFM group, using nearly 20 doses of high-dose pegylated asparaginase, 1,500 to 2,000 per meter square. In the UK, by the way, we only use 1,000. In the altogether group, we have been persuaded to use 1,500 per meter square, but we still take in the UK that 1,000 is enough. So it's the post-remission asparaginase that we're looking to almost get rid of with this approach, as well as reducing the exposure to dexamethasone by hopefully getting rid of the vincristine and steroid pulses. And I'm not going to talk about the results of our most recent UK trial, UCAL 2011, which we published in JCO, but it did show that you could do without those in maintenance in the vast majority of patients. So I'm going to switch from older children to infants. As everyone knows, infants have had a dire prognosis, which didn't change in successive international trials over the last 20 years. Infant 99, event-free survival 50%, infant 06, event-free survival 55%, almost no difference. And so this is a depressing thing, but based on a pilot study we did in the UK, treating 12 infant relapses with blinatumomab as a bridge transplant, the infant group tested whether adding blinatumomab to the very intensive infant backbone would improve the event-free survival. The small study of 30 patients was published in New England Journal, which you'll have seen in 2023, which showed an improvement of disease-free survival compared to infant 06 of approaching 80%. Now it's sitting at 3 years median follow-up at about 70%, to be expected. But we took a different approach in the UK, where because in the expansion of this infant study, they have seen an excess of SAEs with including 8 patients who died during induction amongst the first 30 odd, 8 out of 39, of infections. So remember, even in developed countries, patients die of infections. We took a different approach where I'm not again going to go into the details. We basically used blinatumomab to replace parts of the intensive infant backbone in a slightly different risk stratification. We've treated 33 patients, and at a median follow-up of 2 years, we have patients who responded to blinatumomab having an excellent outcome. Fingers crossed so far. But those who didn't, and this was a small group of 8 patients out of the 30, didn't do as well, but could be salvaged with either post-relapse chemotherapy plus transplant or CAR-T, and in most cases it was CAR-T. So I'm going to conclude my B precursor part of the talk by just summarizing that we should move away from event-free survival to a focus on toxicity reduction, which can be achieved through refining risk stratification using new agents to replace rather than add to chemotherapy. And I think it's going to be really important for people who are running trials to be radical and take the same risk that the pioneers whose treatment approach we're still using took in the 50s and 60s by intensifying chemotherapy. We just need to wind that back, and the new agents offer us a way of doing that. I'm going to end by talking briefly about T-ALL, which is somewhat often in pediatric ALL because it forms only 50% of cases. Traditionally, it has had a worse outcome, but than B precursor ALL, but that gap is closing. MRD is an exceptionally important discriminator of outcome in TLL as well, but it appears to be more important to look at the post-consolidation MRD in TLL than the end of induction. And the TLL seem to have a slower response to treatment, but with a better outcome with the same MRD level at the end of induction. The second thing to remember is age, very important. Age is not a discriminator in TLL. Okay, so adults with the same MRD level at the end of consolidation or even end induction have a similar outcome as younger children. Second thing to remember, if you have a very young child with TLL, less than 5 years old, then you must look for mismatch repair syndrome, okay, especially in consanguineous families, because it's got a very high chance of being a cause of the TLL at that young age. So unfortunately, unlike with the precursor, we don't have excellent new agents for TLL. There are various ones that are going to be tested in future trials. And one of the approaches we are hoping to test in the next altogether trial is in ETP, which seems to be highly sensitive to venetoclax, at least in preclinical studies. We will allocate venetoclax as an addition to chemotherapy. And in the others, we will test giving dasatinib as a randomization. And the remaining patients, we'll probably take a CAR T approach, especially those who have failed induction. And the CAR T that we are hoping to test is one that we've developed at Gosh, which Balwasha will know about, Wasim Kasim, who, by the way, is originally, his parents are from Karachi, has developed this allogeneic, heavily edited CAR T, which targets CD7. He's now treated 11 patients, including 2 adults, with excellent responses, but, and there's an important but, targeting CD7 seems to cause aplasia, and therefore it can only be used as a bridge to transplant, which is highly effective. And of the 8 transplanted patients, 7 are alive at 3 to 6 months. And in fact, he's looking to test the CD7 CAR as a chemo or radiation-free deep conditioning regimen in the future. So I'm going to stop there. Thank you again for inviting me, and acknowledge all my collaborators and the patients and families. Thank you very much.
Thank you, Dr. Ajay Vora, for your comprehensive and wonderful talk. There are some questions. No.
Thank you, Dr. Ajay. My question is,
Pleasure.
I have a 15-year-old boy who had induction failure, 35% blast after 4 drug induction. Then, but he achieved remission, I mean less than 5%, but still MRD positive after NOFO block consisting of high dose Ara-C and daunorubicin. I am planning for 2. I have the access to Blincyto, so he is going to get 2 cycles of Blincyto. What is your recommendation? Should we continue with the chemotherapy arm, or do you recommend stem cell transplant because he has married sibling sister for the transplant? Thank you.
So my our current treatment approach still would be to use the blinatumomab as a bridge transplant. The approach I was proposing is one that needs to be tested. Can Blin alone be enough for such patients with some further chemotherapy, either delayed intensification, maintenance, or maintenance alone? That is something that needs testing before it can be used as a standard of care. So your patient, if it responds to blinatumomab, I would recommend, if you have got a matched donor, should be going to transplant. The only other thing I would say is, did you say he has 5% blasts?
No, he before going to, before starting Blincyto, he had less than 5% blast, but MRD was positive. But we have done the MRD after 15 days of Blincyto. He's MRD negative now.
Excellent, excellent. Well, then that's an important observation, that we have also found that if you do a day 15 marrow in patients who haven't blinatumomab, most of those who are going to respond will have responded by day 15. And in fact, the Chinese, you may have heard, are now using 2-week cycles to save money instead of full 4 weeks. So they give 2 weeks with a 1-week break and then another second 2-week cycle. And they are finding that most patients respond and don't need the full month.
Hello, my question is regarding hypogammaglobulinemia secondary to blinatumomab. How frequent you have seen increase in infection in these patients, and do you recommend any standard practice that how frequently immunoglobulins levels should be checked and how frequently they should be replaced?
Yeah, so unfortunately, I haven't straight answer to this, because the COG trial that I mentioned was associated with an increased risk of both bacterial and viral infections in the blinatumomab arm, did not measure immunoglobulin levels. Now we have, in a subset of patients, and particularly Down syndrome patients who have received blinatumomab are at increased risk of infection from hypogam, not just with adding blin to chemo, but with chemotherapy alone. So we're giving immunoglobulin replacement to Down syndrome. In a future trial that I mentioned, the Altogether trial, we will measure immunoglobulin levels in patients who've had blinatumomab and replace it if they have low levels, so less than 2 grams, or are having frequent infections. So at present, in answer to your question, I would recommend doing it on that basis. Low levels plus frequent infections.
My question is in the continuation of the previous question. As Dr. Tariq said, that there is a patient who has the available of the donor available, and you are planning to give after blina. So my question is that if you don't have the matched donors, what will be the approach for that patient?
It depends what your outcomes are using mismatched donors. If you're happy and comfortable using haplo mismatch with post-transplant cyclophosphamide with good outcomes like the Chinese are, then you would use that as a basis for still proceeding to transplant. But I know that you've had a patient at Shaukat Khanum who one of your colleagues was saying you weren't seeing good outcomes with the mismatch transplants. In that case, I would probably just continue with chemotherapy.
Thank you, Dr. Ajay, for your wonderful time and wonderful talk. Thank you once again.
Pleasure. Thank you very much for inviting me.
This is the last session of pediatric oncology today, and we all are thankful over respectful speakers, audience for this session to attend. And yes, this is the last session. Thank you. Thank you.